You should be here, huh? 4 hours. Because every time they change presentation. I'm not being here. We need one here. I don't know the other options. I need one here for the presentation.
At what time?
We just start from 4 to
pediatric endocrine unit in Adan Hospital. The second talk will be given by Dr. Duha Al-Humaidi, who is a pediatric endocrinologist and the head of pediatric endocrine units in Farmania Hospital. So please, Dr. Maria, take the first part.
Assalamu alaikum. Good afternoon, everybody. Today my lecture will be about an overview of the DSD committee's history. Okay, so when did the idea of DSD committee began? Actually, it began in 2003. It began when the neonatologists were facing a lot of problem with newborns born with ambiguous genitalia, as it was named before, intersex or ambiguous genitalia or hermaphrodite. And they had problems in how to assign the correct genders of the newborn, and it was considered a medical and psychological emergency then. So here came the idea of to initiate a DSD committee, which was dealing with the complexity of cases requiring multidisciplinary team, and there was challenges of gender assignment and ethical dilemmas surrounding surgical and hormonal intervention, and challenges in addressing the psychosocial needs of patients and family, and the individual's human rights and future self-determination. Thanks to Dr. Mona Al-Khawari, who is a pediatric endocrinologist from Amiri Hospital, who is retired, and she was the founder of the first DSD committee in Kuwait. This was the first DSD committee, and the members were only 5 neonatologists and endocrinologists, geneticists, pediatric surgeon, and a radiologist. And I think one of the members of the DSD is here, Dr. Zaidan. And the majority of the DSD committee is now retired. And because at that time, not every hospital had subspecialties, not every hospital had a pediatric endocrinologist or any subspecialty. So this multidisciplinary team was covering, at that time, 5 governmental hospitals in Kuwait. I just added Al Jaber Hospital, it was not covered then, but the 5 general hospitals was covered by this DSD committee. What was the aim of this committee? It was early diagnosis and management of cases, appropriate investigations without delay, and to form a multidisciplinary team for sex offering, genetic counseling, and psychological support. This committee actually was formed following an official decree to meet specific needs within the healthcare system, and it was approved by the Ministry of Health in Kuwait, and it was operated according to the provision of the Civil Service laws and regulation. And this committee was also composed, as I mentioned before, a diverse group of subspecialty to ensure a comprehensive patient care. What was the responsible of this official committee? It was to diagnose, treat, and monitor children with DSD, including determination of sex, and to update clinical guidelines for diagnosis and treatment of DSD conditions, and to review all cases referred from the hospitals, whether it was private hospitals or governmental hospitals. And at that time, it was the dream of Dr. Mona Khawari to maintain a patient registry for all cases of DSD. How did it operate? There were periodic meetings done, and the invitation was by the chairperson. What was the quorum? For a meeting to be valid, the majority of the members should be available, including the chairperson or the vice chairperson, and the reports of this committee work should be reported to the assistant undersecretary with recommendations. This was the first protocol that was done by Dr. Mona Khawari and her team in 2003, which was followed by a revised protocol in 2008. And as you can see, that the vision of that the DSD committee was then also to establish a database registry and to promote genetic study and clinical research. Okay, when the consensus statement on management of intersex disorder was first published online in 2006, the DSD protocol of Kuwait was also updated to change the definition of the previous terminology to disorders of sexual development. Later on, the team expanded. A clinical biochemist was added to the team, and a social worker which was difficult to get and was not always present in all the multidisciplinary team meetings. This was the first DSD software approved by the Ministry of Health IT department, and it was installed in hospitals to register all DSD cases in Kuwait for sake of researchers and to share knowledge and to improve our function. So what were the achievements of the DSD committee then? They assigned a DSD subgroup in each hospital when the number of pediatric endocrinologists increased, and every hospital nearly had 1 or 2 endocrinologists. The subspecialties also increased, and this DSD committee had regular meetings with the hospitals in the presence of the committee members. 6 operated by the DSD hospital subgroups also was done, and by the DSD subgroup, and if needed, the committee would also have a meeting with them. DSD also symposiums and workshops were done, and international experts were invited, and the first DSD symposium that was done was in 2007, and this is the 5th DSD workshop. Also, one of the achievements of the DSD committee, which is the delay in the issue of the birth certificate up to the age of 1 year, if needed, to finish all the diagnosis and genetic diagnosis for a child. In 2014, newborn screening was launched in Kuwait, and 17-hydroxyprogesterone was one of the newborn screening, and it helped in early diagnosis. Later on, in the early 2020s and during the COVID pandemic, there were new rules and regulations for the MOH committee. And at that time, the committee was stopped for a while, but the team was still meeting. But with the effort of our colleague, Dr. Hassal Kendari, who was the head of the pediatric council then, she had great effort in reforming the official DSD committee again. What are the challenges that we faced? We needed an adult endocrinology expert in DSD for transition of care. Challenges in addressing the psychosocial needs of patients and families, unknown risk of treatment like hormone replacement, and ensuring a balance between medical intervention and the individual human rights and future self-determination. So are we improving as a DSD committee? We try our best to maintain communication and regular meetings with the subgroups in all hospitals and as a DSD multidisciplinary team. I think we have a great advancement in the shift from the hormonal diagnostic method, which we still need in some cases, to advanced genetic diagnosis, which was not present before. I think in the last 2 to 3 years, we had advancement in molecular genetic diagnosis for our cases. We get a reply within maybe 4 to 6 weeks. Psychological assessment also was an add to our DSD meeting in the last 2 years. And we had good psychological support from our psychologist, I don't know if she's here, Dr. Afra, that supported the patients from early diagnosis until the sex of rearing and post-diagnosis. Great effort has been put into proving the DSD registry, which will be presented to my colleague, Dr. Waha, which is putting great effort for this registry to succeed. Frequent workshops has been done and invited the expert to share knowledge, and this is, as I mentioned, this is our 5th workshop. Okay, are we facing other challenges? We are used to, as a DSD committee, to deal with any case which is either a newborn period or in the early first years of their life. Recently, we had a challenging case for the first time in the DSD history. We faced a child who was almost 14 years, assigned as a girl, and was present by our colleague from Mubarak Hospital yesterday. And this child has a gender identity of a male, and after 1 year of frequent meeting with the DSD committee, it was decided to raise this child again as a male, and we succeeded in changing the sex birth certificate, and we're going to change the civil ID and the school. So I think this is the first challenging case that we face, and I think we are going to see more cases in this age group. I would just, this is our DSD team that further expanded by an adult endocrinologist with interest in reproductive medicine, a gynecologist, a figure from Al Sharia, a psychologist. And I would also to express my special thanks to all the pediatric endocrinology units in Kuwait who helped in succeeding in the succeed of the service of the DSD committee. Our pediatric urologists, radiologists, we only have 2 pediatric radiologists in Kuwait who they usually revise the MRIs and they repeat the ultrasound if needed. Thanks to our geneticists for the great effort. Of course, a special thanks to the only pediatric urologist in our team, which is Dr. Abdel Nasser, and he's 724 and he answers all our questions and available every time. And of course, thanks to our pediatric psychologist. Thank you.
Thank you, Dr. Maria. And we'll give the second part talk to Dr. Roha to give her experience regarding establishing the DSD committee.
Assalamu alaikum. Thank you, Dr. Maria, for this introduction. So now I will talk about our research that is based on doing the genetic testing for this DSD and to enhance our DSD registry. So to start with the introduction, Kuwait, as other Gulf countries, have a high rate of consanguinity, reaching 40 to 50%. And this will raise the incidence of heritable diseases in DSD. Genetic diagnosis as a part of DSD evaluation is very helpful in evaluating and confirming the diagnosis. Why we would like to do that? To improve our care for these patients. Having genetic diagnosing and establishing registry will help us to guide personalized and clinical management and treatment for these patients. It will also help us to assist the inheritance and for family counseling and to inform and it has to improve the gender assignment and the long-term psychosocial planning. It will also help us to identify people who are at risk of associated conditions such as gonadal tumor. So let us go for one of the example, which is Farwania Governorate. Farwania Governorate hosts around 1,230,000 people and it's around 25% of Kuwait population. During the last year, it have 4,800 live births in Farwania Hospital, which is considered as a secondary hospital covering the drainage area of Farwania area. So we review our data in the pediatric endocrine unit and we did a chart review to see how many patients were registered in the last few years. We found a total patient of 45 patients who were diagnosed with DSD. Of these, the karyotype was 46XY in 21 patients and 46XX in 15 patients. And one patient was Turner with 45XO and one patient had a chromosomal sex disorder, which is 46XY, 45XO. 7 we didn't have the information because unfortunately they missed follow-up. Of these patients, how many of these had genetic testing? Unfortunately, we are not doing very well in doing the genetic testing for these patients. So only 12 out of the 45 have confirmed genetic diagnosis. The reason of that, because of some limited resources in doing genetic testing, because they are prioritizing the genetic testing for urgent or critical cases. Regarding the diagnosis, for a patient with 46XX, most of these patients, if not all, we have confirmed clinical diagnosis. So out of the 15, 14 were having 21 hydroxylase deficiency, 1 with 11 beta hydroxylase deficiency, but 9 out of the 21 patients who were diagnosed with 46XY have a clinical diagnosis when we are evaluating them. So what is our aim in our study? To describe the genotype-phenotype correlation of DSD cases in Kuwait and to do genetic testing of eligible participants with DST by molecular genetic diagnosis, and to enrich our DST data, our DST registry data. So our method, we implement a study which is a cross-sectional study to study patients who are diagnosed with DST in the last 10 years. Our sample size that we are proposing to have is 200 subjects, and these will be recruited from pediatric endocrine clinic. Collection sheet have some fields such as the demographic characteristic, the medical history, and general and genital examination. Thanks to Dr. Cruz and her team for implementing the external genital score that will help us to decide which child is having a significant ambiguity that need to be tested and evaluated. Also, it will have the karyotype result, the biochemical profile, the radiological exam, and the hormonal stimulation test. So these patients who are diagnosed with DST will be enrolled from the pediatric endocrine clinic or the various sites, as I mentioned. And then after evaluating these patients and making sure that they are fulfilling the inclusion criteria, they will be enrolled. And then after enrollment, we will refer them to the genetic center, which is the Ghanim Al Ghanim Genetic Center, in order to do the genetic testing. Our plan to do an NGS panel which contains 35 gene mutation associated with DST. If it is negative, we will do a whole exome sequencing for these patients. So where are we from this study? So currently we have 23 patients. We started in February 2025 with 2 patients, but unfortunately in March it was Ramadan, so we stopped in Ramadan, then we come back on April, and then we started in Farwaniya as a soft big kick-off, and then after setting up the logistic, we start to put other centers such as Adan and Jahra, and inshallah we are going to have other centers in the future in order to improve the enrollment. So our population or our patient or our cases, 13 out of 23 were Kuwaiti, and Farwaniya was 14 patients, Adan was 6, and Jahra Hospital was 3 patients. Consanguinity was positive in 10 out of 23, and the sex of assignment was male was 11, female were 10, and unidentified at birth was 2 subjects. Karyotype, 12 from our patient were having 46XY and 10 were 46XX, and 1 patient had 6 chromosome DST. These are some of the clinical diagnoses that we found them in these patients based on the workup that was done for them. So what is our future direction? Our direction is to involve more sites, to enhance our enrollment, to enhance our enrollment by putting more sites from the pediatric endocrine, the NICU, and the genetic center. And then we will have also the pediatric urology center, because some cases, unfortunately, we are missing them and they are only following up with the surgical department. Also, to our future direction to have a descriptive analysis of this large cohort of DST cases in Kuwait, and to evaluate this cohort based on the genetic, psychosocial aspect and long-term outcome. Having a registry will help us to call and follow up these patients to see how they are doing in form of puberty and fertility. Also, by doing whole exome sequencing, it will help us to discover new novel genes that will enrich the database of DST. Also, we want to enrich our DST registry, as Dr. Maria mentioned, that it was started, and we would like to enrich this DST registry in Kuwait. So by saying so, I would like to acknowledge the Ministry of Health for supporting this research and for sponsoring it. Also, I would like to acknowledge Kuwait Foundation for the Advancement of Science for funding our research. I would like also to acknowledge our research team in Parwania Hospital, Adan Hospital, and Jahra Hospital, and the coming, inshallah, collaboration with other teams. I would like also to thank the patient and the family for their participation, and Ghanim Al Ghanem Genetic Center for evaluating and doing the genetic testing for our subjects. With this, I would like to thank you all.
Thank you, Dr. Dhaha. I just remind you that we'll keep the questions till the end. So proceed with our second part of this session.
It's my pleasure to introduce next speakers, Mrs. Hayden Bandit Bush, clinical psychologist and psychodynamic therapist in Pediatric Department of Medical Psychology for Children and Adolescents in Ghent University in Belgium, and Professor Martin Kould, pediatric endocrinologist in Ghent University in Belgium. They will be speaking about gender assignment and follow-up of gender identity challenges cases.
Okay. So hello everyone once more. We will present some cases together regarding gender assignment and follow-up of gender identity. And I will introduce a little bit the medical part, and then I will give the word to Heidi for the rest. So the first case is a baby with atypical genitalia, born in a regional hospital, and the baby was really referred in a kind of emergency situation to our NICU unit after a very difficult and painful delivery because of the presence of atypical genitalia. However, although everyone was in panic, actually the baby looked very healthy, and the physical examination was unremarkable except for the presence of these mildly atypical genitalia, and the mother really thought that her baby was in danger, and she was not even allowed to hold her baby. It was taken away immediately to be brought to the referral hospital. Nonetheless, we thought that it was quite difficult to do an immediate sex registration because actually the situation with bilateral gonads in the labioscrotal folds and some mild clitoris hypertrophy could fit with multiple diagnoses and gender outcomes. Upon the first hormonal workup, we saw that there was very high AMH and also testosterone, so this was compatible with the tentative diagnosis of partial androgen insensitivity syndrome. We decided together with the parents to raise the child as a girl because of the very limited virilization that was seen at birth. Genetic investigations confirmed this diagnosis. In the beginning, this was very, very difficult to establish a good parent-child binding. The mother experienced a postnatal depression. There were several hospital admissions for the baby due to excessive crying, but this all improved with time. Nonetheless, we had several questions with regard to the future of this baby. Will the child, while growing up, develop a female or perhaps a male gender identity? Will she experience virilization at birth given the diagnosis of partial AIS? Will she experience breast development at puberty? And will she need gonadectomy, either because of unwanted hormone production or because of germ cell cancer risk? And will she be able to decide about this herself? So the management plan that we foresaw for this child was, we thought it was crucial that she could be able to fully understand and oversee her condition and the consequences around the age of puberty, as she would need to take this decision as much as possible herself. So we stimulated openness about the condition with the family. and we discussed the different pathway of sexual development with this child already from the age of 4 or 5 years. We counseled the family to avoid overemphasis on typical female toys, typical female dressing, and to allow her to develop an interest in and an exploration of other possibilities. I hope we will have the slides again, the patient back. So, okay. Oh, that's right. Seems to be finished. So, and I will maybe continue the story meanwhile. At the age of 8, we started to discuss with her how the body changes during puberty and what it means, actually, puberty. And we started really to discuss how her body works and what the decision was that she needed to take. And then we sent her to Heidi for further workup.
Okay, so then I met a girl, and of course, because we wanted an answer for the future medical questions, I started a gender exploration, and the main question for her was the main theme. Is it okay that I am who I am? Is everybody accepting it? And of course, we take into account the parents, but with this little girl, it was quite a pitfall of expectations, because as a doctor and psychologist and as a parent, we sometimes think that we know how the child feels, but sometimes it evolves in a different way. Let me show you. I started, and it's a technique I use quite often with children, to draw a body diagram. I just make it with children themselves to connect. And then I ask them to color it in a color code. The green parts of the body are the parts they are happy with. The orange parts are the one that they don't like that much. Maybe they work well, but they don't like it, or the other way around. And the red parts are the ones that they dislike. Now, this girl started first to draw everything green, and then the genital area she colored orange. But then, after a while, she took again the green pencil and she drew over the orange. Another technique I use is gender continuum. And over here I explain to the children that when you see like a group of 100 girls, there's a small group of girly girls, and there's at the other side of the spectrum a group of tomboy girls. And like we divide the group of boys in the same way. You've got a group of more softer boys, and then at the other end of the spectrum, a group of more male-ish boys. And then I asked them where they would put themselves. They put a cross on it. And I also ask where they think their mom or their dad will put them, or how they react to them at school, where the teacher will put them. And so with this girl, it was a long time, and during the story, it was quite clear. She felt a bit more like a girl. It was okay for her. And when you remember the body image, you can tell about the genital parts. They were a bit difficult for her. We keep talking about that also. But after a certain time, her mom emailed me and said she wanted to see me. She wanted to discuss something with me. And her mom said, I think she is going to ask for an operation. But when she came over to me, she just wanted to say, I think I am a boy. So that was a pitfall that everybody already taught in front or before that we know whatever she wanted. Now at this point, we are a year later, you can tell that for her it was like I needed to mention it, but now she returned again to it's okay, I am who I am, and nothing needs to be done at that age. So at this point, I still keep seeing her every now and then, and I think it's a good way to explore and to talk with the children themselves.
Okay. So the second case is again a baby with atypical genitalia, referred for the workup of this situation, and in the family there is an aunt with classic CAH, and to cut a long story short, the workup of this child showed that she also had CAH, and we started the treatment, and we started vaginoplasty and clitoris reduction at the age of 2 months. This is still in the period that we did early genital surgery. So in the first 10 years of her life, there was rather difficult hormonal control of CAH. She also developed as a tomboyish girl, but a bit like other girls with CAH. She developed an enlarged clitoris around the age of 7, also a severe obesity problem, and there was a very strong deterioration of hormonal control at the age of around 11, as you see on the right side, with 17 OHP reaching almost 11,000 nanograms per deciliter, androstenedione 10 times the upper reference. So it was clear, I think, that there was a compliance problem. We increased already the dose. We discussed that it was not safe, that it was not good for her health not to take the medication. Meanwhile, we saw that the obesity problem increased, that the style of dressing changed a little bit towards more male-ish style. She mainly wore sport clothes. Also, she became a little bit more withdrawn in herself, was more difficult to communicate with her. She developed voice deepening, acne, striae. At the age of 12, I had a very open discussion with her. Like I said, I know you're not taking your medication in spite of what you tell me. And this causes high androgens in your body. This causes the changes that I can see and that you can also see. And I think I need to send you to a child psychologist because I want to know what this means for you.
So, when I started to see her, the main theme over here was, who am I? Because I don't think my body fits. We talked first about normalizing the gender confusion, that it was okay for her. I repeated again the psychoeducation, but it was a girl that wasn't that strong on a cognitive level, so we tried to explore it several times. And then for the gender identity, we started looking. Now this girl was older, and then I used some questionnaires. One of them is the body image scale. I put the Dutch one over here because I wanted to show her version. And there are a lot of body parts on the left side, and then they are asked to indicate how they feel about them, going from very satisfied on the left up until neutral in the middle, and then really unsatisfied with his body parts. And at the right side, there's the question when you have like a magical wand, and you can just like this change that body part, would you do it? And for her at that moment, quite a lot of things were neutral, meaning I don't think about it, or it's fine by me. And only her height and her body weight were things she wasn't happy at that moment. Another questionnaire I use is the recalled childhood gender identity, gender role behavior. And over there you look at the time, they think back on that period between birth and 12 years of age, how they react to others, what they like to play with. And it's a questionnaire, but I talk them through with them. for her, in the beginning, you can tell by the body image scale, she was a bit reluctant, but after a time, she started really telling and showing that she felt more like a boy. So we thought, okay, we're gonna reassure her, we're gonna say that we comprehend her, but it still needs to be safe, she needs to be healthy. So we kept on going on, like, fine for us, okay, if you feel that way, but the blood results stay poor. And it was only up until the moment that we discussed to start puberty blockers that she showed some sign of relief and was really like, okay, I think I need that. And in the beginning, I thought it was going to be a bit difficult for the parents, but they showed the same relief, like, okay, we really think our child needs this. At this moment, she's still on puberty blockers. When we are proposing the idea of, okay, do you want to get on cross hormones? She's not really reluctant, but she's not eager to start with them. And like changing her name or something, at this point, she says it's fine by me. So we're still going to see in the future how it goes on.
And the compliance with the medication has very much improved as well, so I think that's important. Then the last case is a 1-week-old neonate, referred also for workup of atypical genitalia. There was some mild virilization, mainly micropenis was seen, and bilateral impalpable gonads. Conventional karyotype was XY. There were some limited hormonal investigations, and the diagnostic workup showed in the end the likely diagnosis of bilateral testicular regression. Male sex was registered, supported also by the parents, and this was in line with the recommendation of the Chicago Consensus Meeting for Children with BTR. We did a trial with testosterone supplementation and also DHT cream in the first year of life. Unfortunately, this did not result in better phallic growth. At the age of 12, he still presented with micropenis. Overall, he had female-looking genitalia and also a female fat distribution on the body. So for me, it was very clear that we needed to start puberty induction. But I felt very uncomfortable because how I knew him and how he was talking to me about his life, he told me that he had absolutely no preference for male or female friends, and he didn't really like to play with boys and engage in typical boys' play and behavior, and his parents also describe him as a very soft and gentle boy. So I did not want to start any testosterone treatment before I was certain about a male gender identity. And again, I referred this boy to Heidi.
And his key theme was, who am I to others? For him, it was really important that whenever he was going to start with some kind of cross hormones, that he didn't, that he wouldn't be seen in a particular traditional way, like a traditional boy or a traditional girl. So it was a really long trajectory. He needed quite a lot of time, quite a lot of space. It was really tough for him to discuss this also at home. So we invited the parents several times together because it was for him important that they were supportive, and they actually were. But for him, it was really difficult to talk about it. For him, the gender continuum, he was really in the middle, but he couldn't express it properly. He could only refer to concrete actions, like, maybe I am a bit like a girl because I like to sew and I'm creative, but maybe I'm more like a boy because I like to be active, I like to dance hip-hop style. And for him, it was really important, the moment that he decided to start, that we start with an extreme tiny doses, a symbolic one, even less than the smallest dose. Later on, I'm going to show how they keep in charts of building up the doses and the frequency of the testosterone. And at this point, for him, he's really saying like, my body is okay, it fits. I needed to make actually a choice with which kind of sex hormones, because I wanted to be healthy. My body is okay, but I feel my identity is DSD. So at this moment, he's like, he just started university, he's doing well, but he really needed a lot of time to think it over. Okay, thank you.
Thank you.
Thank you, Professor Coles and Mrs. Hind.
Our third part guest speaker is Ms. Bridget Van Hoort, who is a psychologist, sexologist in the Center of Sexuality and Gender in the Ghent University Hospital. She's also a member of the DSD team and gender team. She's going to give a talk regarding how to manage young girls who are considered to go for vaginal dilatation therapy.
Okay, thank you. Good afternoon. So indeed, I will talk about the vaginal dilation therapy in young women. I only see people from 16 years and older. So I will start with a short introduction, then I will talk about the consultation with the psychologist and also the role of the pelvic floor physiotherapist in the dilation. Then I will tell something about the dilation practically and how and when it stops. And I will end with some advantages and disadvantages of dilation. So when women want to start the dilation, the first person they see is the gynecologist. In our hospital, we have some gynecologists who are specialized with adolescents and young adults. Afterwards, they send them to me as a psychologist, sexologist when they are 16 years or older. We prefer not to start before 16 years, but if there are questions before, they were sent to the child psychologist, to Heidi. When we think they are ready to start the dilation, we send them to the pelvic floor physiotherapist. In our hospital, our first choice treatment for women with a DSD diagnosis who has not enough depth of the vagina is dilation. And dilation is a gentle pressure with dilators to gradually increase the length and the width of the vagina. Here you see the dilators we use in our hospital. So you have 4 different dilators with one handle, and they all have different size. There differs in length and in width. Other treatments there are more surgical treatment. When I start a consultation, I have a lot of general questions because I want to know who the woman is before me. I want to have an idea of her life. First, of course, I start with the diagnosis. When did they get the diagnosis and how? What did this mean, the diagnosis for them, and how did they deal with it? Sometimes, because I didn't say it, most of the women I see have an MRKH diagnosis. MRKH is the Mayer-Rokitansky syndrome. So they have 46 XX chromosomes. They have normal external genitalia, but there is no vagina and no uterus or a vagina or uterus who is underdeveloped. They get the diagnosis mostly at a later age when there is no menstruation. So it's possible if they come to me for dilation that the diagnosis was recently, and then at that moment it's important just to check the emotions they are around the diagnosis, and when you see that the emotions are still too strong, it's better to wait a little longer to start the dilation. I also ask them with who they can talk about the diagnosis. I talk about their body image and their self-image, because when you do the dilation, you have a confrontation with your body, so it's interesting to know something about that. I also have a lot of questions about their daily life. Do they study? Do they work? What do they do in their free time? Because she have to dilate every day, and I just want to have an image of her day to see which moment is the best to do it. I also ask questions about relaxation, or are they more a person who has a lot of stress? Because also for the dilation, it's important to feel comfortable and to feel relaxed. I also ask them to describe themselves. Also, this could be interesting. Sometimes a woman says, when I have a goal, I am someone who goes for it. Or maybe another woman says, I'm more a lazy person. So also this could be interesting. I also ask what feelings they have about the dilation, what they expect from it. I also show there the dilators. It's interesting. Sometimes it's the first time that they see them, and it's interesting to see their first reaction. And of course, I ask questions about their motivation. Then I have some more specific questions about relational history. Have they already had a relationship? Is the partner aware of the diagnosis if they have a relationship? And I also ask questions about the sexual history. Do they already have sexual experience with a partner? Or do they already have experience with masturbation? Because also this could say something about the connection that there's already with their body. What is important when we want to start with dilation? Very important is the motivation. On one side, you have a more intrinsic motivation. If they say, I want to have a vagina to be normal. At the other side, you have a more extrinsic motivation. I want to do this for my partner, or sometimes with more younger adults, if they are on a consultation with their parents, you can feel, or they say it's more something that I have to do from my partners. In these cases, I find it very helpful to see the adolescent or the women alone, because there were stories in the past that they tell me another story if I see the girl or the adolescent alone. I have cases where they tell me, oh no, I have more feelings for women, I have more lesbian feelings, and I don't think penetration would be something for me, so I think that dilation is not necessary. So this is all important information for us. Also, maturity is very important, and maturity is something different than age, because a person of 16 could be very mature, but otherwise you have persons who are 18 who are not mature. Also important is that they are comfortable with their body, because the moment that they start with the dilation, every day there will be a confrontation with their body. And we also find it important that there are no psychological contraindications. For example, depression. When they feel depressed, most of the time they don't have energy. So at that moment, it's not the right time to start with dilation. And it's better first to handle the depression and afterwards to start with the dilation. So we evaluate together whether the woman is ready or not. It's their choice to do the dilation or not, but we look together with them what is the right moment to start, because in our experience we have the idea that it's really important to look for the right moments, because I sometimes have the feeling we only have one time to start the dilation. There were women who stopped after some weeks or months because it was too hard to do it, and then it's really difficult later on if they want to start again the dilation, to find the right motivation, because they already did it, they had some negative feelings around it, and then we see that it's really difficult to start later on. So that's the reason why we find it very important to look for the right moment. So the success of the dilation depends on the time investment, the motivation of the women, and the therapy compliance. So it's really important to have an adequate psychological and sexual guidance during the process, and we do it with our multidisciplinary team, and especially for dilation, we have a central role for the gynecologist, for the psychologist, and for the pelvic floor physiotherapists. So I said the important role of the pelvic floor physiotherapist, because we as psychologists, we work with language, we work with words, but the physiotherapist works with the body of a person. She can show anatomical images. Sometimes we already did it in our consultation, but she could also look together with a woman with a mirror to the genitals. Sometimes also this is the first time that a woman does that. She gives information about the contraction and the relaxation of the pelvic floor, and not only information, but she also checks if they could do the contraction and the relaxation. So she guides the patient in a more practical implementation, and if the woman is ready for it, if the woman wants it, it's possible in the first consultation with the physiotherapist to have a little demonstration and a practice of the placement of the probes. So we follow them during the whole time that they are busy with the dilation, and we evaluate on a regular base by our team. And the most central role at the moment they start is for the physiotherapists, because every 6 weeks there will be a control, and it's really good for the women, because at that moment they know how it's going, because at home they are dilating, but it's difficult to say, do I do it good, or do I have evolution? And when there is a control with a physiotherapist, she can measure the depth that there is already, and if they make some centimeters more, also that this is a motivation to do further. These are some images how to put the dilator in. So concrete, we ask them to dilate daily between 20-30 minutes with some pressure. We ask it to do it daily. We know that some persons don't do it daily, because it could be that there is a day that they are sick, or that they really don't want to do it, but we ask it to do daily, because maybe when we ask to do it 5 times a week, maybe they just do it 3 or 4 times. That's the reason why we ask to do it daily. We look for an uninterrupted time, because the moment that they start, we find it important that they have several months before them that they could do it every day. We look if there's sufficient privacy at home to do the dilation, and we look together what time is best. That's the reason why I asked the question about the daily life. Some prefer to do it in the morning, then afterwards they don't have to think about it anymore that day. Some women prefer to do it at the end of the day when everything is done. But when you do it in the morning or in the evening, it just has to become something like a habit. And it's important to be relaxed and to look for things that can help them to relax, and also the physiotherapist can give some tips about it. I propose to do the dilation apart from the intimacy and the sexuality with a partner, if there is a partner. Dilation is at that moment that they start something that they want to do, but it's also something that they have to do. And dilation, even if they want to do it, it's not a pleasant thing to do every day. And I really find it important that intimacy and sexuality with the partner stays a nice and pleasant thing. That's the reason why I say to do it apart. When do we stop with the dilation? When successful penetration is possible, most of the time then we have a depth between 8 or 10 centimeters. How long does it take to go there? We say, and I know it's a broad range, but between 6 and 12 months when they do the dilation daily. And of course, it depends on the start depth of the vagina that they have in the beginning. Sometimes it's just half a centimeter. Some women have 2 or 3 centimeters in the beginning. So that also is important to say how long it will take. And how to maintain the depth when they are in a relationship. We say, okay, if you have regular penetration, it's okay. If there is no relationship, we say to continue the dilation, but at a lower frequency, maybe once a week or twice a week. So what are the advantages and disadvantages of dilation? Advantages, yeah, it's relatively easy to do. They need no hospitalization. They have control themselves. You have the preservation of the vaginal tissue. It's more cost effective. There are minimal complications. And if it doesn't work, the surgery is still possible. The most important thing that I hear from the women is that they could make their own vagina at themselves without surgical intervention. The disadvantages, the importance of the motivation and the maturity. It's time consuming. We know that we ask a lot of the women. The discomfort and the pain, we say it's normal that you will have some discomfort, but we don't want them to have pain. The most difficult thing I hear is the daily confrontation that they have with their diagnosis, because like the MRKH women, before they start the dilation, they could do a little bit if there's nothing wrong. But when they start the dilation, they have every day the confrontation with the diagnosis. If you don't continue, you could lose the depth. And that's still a difficult question at the long term. Is dilation required or not? A colleague of me makes a brochure with 10 tips for the dilation. You could also find the brochure on the DSD Teens website. There are a lot of pictures and colors in it, so it's a very nice thing for the women. I put here the 4 first tips. The first one, create your support map. So see that there are people around you who can support you, who can motivate you. Second tip is about the right material around you. The third tip is about the mindsets, the right mindsets, to look for some relaxed things. A fourth tip is to make some you time and to look for the right, for the good privacy. And so there are still another 6 tips in the brochure. So this is the end. Thank you for your attention.
Thank you, Ms. Bridget, for this enlightening talk for an aspect usually we don't see as a pediatric endocrinologist, but we have to face it as in adolescent period also. May I ask our guest speakers to be on the stage here for any questions, please?
Thank you, Prof. Kuz, Ms. Heidi, and Ms. Bridget for this nice talk. My question is that we had a similar case. So when I was doing my fellowship in Saudi Arabia, we have a boy who was initially raised as a boy because of his genitalia, but with the workup we find that this is 46XX DSD, secondary to salt losing, non-salt losing, simple virilizing CH. And unfortunately, because of the bad control, this patient was raised, as what we know, that this patient was raised as a female. But with the bad control, the patient was resisting this sex operating as a female. So, and the family was trying to overcome this because of the social thing. And then finally, when the patient became adult, he said he changed his sex from female to male. And the reason for that he was really suffering from the bad social stigma, that how he will change himself from female to male. So we face these patients also here. So if you can also elaborate more on this point.
Yeah, it depends a little bit on what you want to hear. I think for me, one of the main lessons in this case that we presented was that, well, this child had genital surgery at the age of 2 months. So genitoplasty, vaginoplasty, this doesn't help or this does not ensure, let's say, that a female gender identity will develop. I don't know to what extent the difficult metabolic control during childhood has a cause in this evolution. I think that's very difficult to know. I'm sure it doesn't help. It's very confusing for children when they see their body changing. At a young age, they don't understand that this is due to the androgens. I have learned also from this case that I think as a pediatric endocrinologist, we really need to explain to the children that, well, when a few years ago I was still a little bit reluctant, and also for parents this is sometimes very difficult to accept that I tell them about virilization if they would not take the medication, especially for young children. And now I'm more and more convinced that we need to do that, although it's difficult. It's also difficult for me. But I think it's important that children know and learn to understand what really happens in their body. So, well, we can discuss afterwards how we do it and what's the experience with it, but that's probably one of the most important things, that we need to name it, that androgens are produced that cause changes in their body that they might not want.
Just gonna add, because I agree, because it was like the pink elephant in the room. It was, you could feel it by the way the parents were supportive immediately, and the child itself, the complete relief that she's shown. So I think it was always there, but we needed to give the words to it.
Hi, I have a question here for Professor Coles and Ms. Boucher, I guess. For the second case you presented, you mentioned that there is you gave the patients pubertal blockers. Do you consider this like an intervention in the natural progression of where the case is going to go, and you're intervening with the natural progression of the case?
Yes, probably in a way it's an intervention in the natural progression. It was in the way we felt it, and the way this adolescent told us it was necessary to take away the pressure from this medication effect and to give this adolescent some space to really explore gender identity without a confusion with taking the medication or not. Before it was a kind of affirmation also that all these things were coming together, and that if we could arrest puberty, at least it was somehow reassuring. And at that moment it was like the only option. And I think also it's nothing dangerous to do. You cannot do harm with it as long as you don't do it for, let's say, 20 years or so.
Yeah, maybe somebody will see it on the other side, saying just leaving the natural puberty happening, and this might help us where to go and help the kid where to go.
I think that's true for if puberty would not have started yet. So if you start puberty blockers, GnRH analogs, already before start of any puberty, then there is impossibility to experience what puberty does. But this girl had peripheral precocious puberty and central puberty, and she experienced what all these changes did, and she didn't want it. So that's a clear difference, I think. It's very important to allow spontaneous puberty to continue for a while, for the child to discover what this does with her.
So this case, she had her puberty already, and then you block it?
Yeah.
Oh, okay.
Yeah.
Thank you.
Thank you for the beautiful session today. My question for Ms. Birgit, and again, thank you, Ms. Birgit, for bringing up this topic, which people probably in our part of the world might find it, difficult to discuss and odd to discuss. You did touch on the pelvic physiotherapy, and I want to know more about this, specialty and how closely this specialty is working with such patients who are going the vaginal dilatation.
And which specialty you mean? Sexuality or a pelvic floor? Yeah, I'm not a pelvic floor physiotherapist, but by the dilation, it's very important because they use their pelvic floor muscles. It's really important that they can relax them, contract them to bring the dilator in, and we have also a specialist for that in our hospital. It's something also. She also guides patients who had a vaginoplasty. So we have an important role for our pelvic floor physiotherapists.
Thank you. I'd like to comment on this assessment from Marina, the one who was having gender assignment early on in life, then puberty was only 14. That gender was changed to the other sex. So the worry is that when he or she get to full adulthood, have you seen patients or subjects who regret that decision during adolescence and won't go back to the original sex? Because the decision was taken at the age of 14. The child desired to go to the other sex, but again, they might change their mind when they're 21, 23. Have you faced cases like that? Will you wait till 18 since...
To my knowledge, we have not encountered adolescents who were asked to, or who were involved in the decision, let's say, and who changed their mind afterwards. No, not to my knowledge.
I agree, and I think we take as many time as needed, because sometimes it's a shorter period of time. But like with that one boy, it took years. We decided, so they're allowed to take the time they needed, and I think that's most important part. And they know they can think about it. We had it at the Manera Hospital about it. We say sometimes it's also okay that you don't know it now. Uncertainty is okay, it's allowed. We don't have to decide immediately. We go through the process and we see where we end up. So quite often as a medicine doctor, I think we really want to solve the problem, to start treatment. We think, okay, then it's quite clear, everybody's happy, parent, child, but sometimes be able to carry on with uncertainty is part of taking care of the medical trajectory.
Just to make it a little bit more concrete, I thought around the age of 12 of this boy to induce puberty. I think we started with testosterone at the age of 16. We continued with 25 milligrams per 4 weeks for quite a while, almost a year, I think. And it was only, each time when there was a visit, he was first seen by Heidi, and only if I got the approval from the boy that the dose could be increased, that we increased. So it was extremely slowly.
So the worry us as physicians that, okay, we did, clinically, psychologically, and the decision was shared with the parents, with the child, so everything is fine. But then comes the legal aspect of it, because he's still a minor. So at any point of time, if these kids change their mind when they're full adult, then comes the legal aspect that we're not sure about. Have you faced any court cases that they will come at later on and then sue the whole team regarding that I was a minor, regarding the decision taken at that time, I was a minor, though they were involved and the parents were involved and all the specialists were involved, but still they regret and they come back and defend their case based on we're still minor, so we don't have the full authority to take decision.
In our team, I can be sure we have never experienced that. There has been a case a few years ago from another hospital, a woman with myelorokitansky who had a vaginoplasty, which she regretted because this was full of complications. And she said, well, at the moment I was, I think, 15 or 16. But doctors said to me that I had to do it to be like a full woman. And so I agreed because of that argument, but now I think that argument is not valid anymore. And it made my life horrible. There are so many complications, and I don't think it was the right argument.
Thank you. By this, we will conclude the first session. We will have a short break for prayer and coffee break. Thank you.
شلونكم دكتورنا؟ اخبارك طيب؟ يحيى الظاهري وياك قلت شيخ صراحه. يا مرحبا. كيف اخبارك طيبين؟ وياك.
والد ما شاء الله له جهود كبيره في افغانستان اليوم.
ايه الحمد لله.
بس ما شاء الله قاعد اتابع هذا قالوا حرب خلقي صراحه. بس ما
لا كلام. بس الحمد لله يعني كان قبل الحين.
انا حطيت كلهم اساسا بس
رحيم. السيد بدر.
خمسة. Yes.
سابق عصر.
جزاك الله خير. أنا بالله
رائع.
Yes, we will start our second session. Please, our guests, take your seat. Still? We'll wait for our tech support to finish setting up. I hope to say your name correctly. The microphone. Our apologies, we have some technical difficulties. We're just waiting for our tech support. And we will start momentarily, inshallah. Have a seat, Dr. Hannes, have a seat. Yes, we can start? Yes. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. And thank you for joining us for this second session. I'll introduce myself. I'll be co-chairing this session with my colleague. I'm Dalia Abdelrazak, a pediatric endocrinologist at Mubarak Al-Kabir Hospital and Jaber Hospital. Here with me, Dr. Noor Al-Mtairi. She's a pediatric endocrinologist at Jaber Hospital. It gives us great pleasure to introduce the first speaker, Dr. Hannes Siren. Dr. Hannes Siren is a clinical geneticist at the Department of Biomolecular Medicine at Ghent University Center for Medical Genetics at Ghent University Hospital, Ghent, Belgium. And he'll be talking to us about pathways in genetic diagnosis of disorders of sex differentiation. Dr. Siren, you have 20 minutes when you start.
The presentation
We were just looking for the presentation, so I'm sorry.
So once you start it, you'll have to tell it. Don't worry, we'll wait. Don't worry. We apologize for the delay, some technical errors that we are tackling at the moment. Thank you for your patience.
Okay.
Thank you, everybody, for waiting. Now we will start. Dr. Hannes, go ahead.
Thank you. Sorry for the delay. So in this second genetics presentation, I want to go a little bit more practical in how we can reach a genetic diagnosis. And this is a diagram that's already been shown a little bit to you. And this is something that we can use to try and make a differential diagnosis and try to come to the right molecular diagnosis as well. And I will guide you through it a little bit through a few cases. So the first is a female of 21 years old, and she was referred for primary amenorrhea. The ultrasound could not visualize any uterus, and there was breast development from the age of 13. So the first things that come to mind here as diagnosis are MRKH, congenital adrenal complete androgen insensitivity syndrome, rather. Maybe congenital or complete gonadal dysgenesis, but then you wouldn't expect the breast development. But then asking a little bit further, we can see that she has a younger sister with the same at 17 years old, I believe it was, also with primary amenorrhea, and there was a maternal aunt that could not have children. So which makes the diagnosis of MRKH less likely, and the androgen insensitivity a bit more likely, and she indeed also had an AMH in the male reference range with high testosterone and a karyotype of 46XY. So let's look at our chart. So this is an isolated case of these not syndromic. We have a XY karyotype that we could determine with the techniques I explained yesterday. And then to get a bit more subdivision, we can look at some important science, namely is there a uterus and what does the hormone test say? And in this case, we could not find a uterus, and there is an elevated testosterone, which indeed leads us to the diagnosis of androgen insensitivity syndrome with the presence of a pathogenic AR variant. Alternatively, There is always a way to immediately start more extensive analysis with a targeted panel of a few genes or with exome sequencing, which can sometimes be faster in case the first diagnosis is not the correct one. Then you would have to do 2 steps. But if you have a targeted approach, it can save, of course, on resources as well. A second case is a prenatal case with an XX karyotype on the NIPT. But the ultrasound was suggestive for a boy, and indeed postnatally there was typical male genitalia with the absence of gonads in the scrotum. And then we again did our anamnesis and family anamnesis. There was maternal virilization in the pregnancy, and they were originating from the same village in Turkey. Some hormonal results, we had an elevated testosterone, and the 17-hydroxyprogesterone was normal, and no uterus or gonads could be visualized. So again, let's look at possible diagnoses. This is again an isolated case. We have an XX karyotype, and here it gets a little bit tricky because sometimes the uterus is not visible because it is very small. In this case, we can see that the 17-hydroxyprogesterone was normal. It could also still be in the category of the testicular over-testicular DSD, but in this case, it was a case of aromatase deficiency, also given the maternal virilization, and we found a homozygous class 4 variant in the responsible gene. Again, it can also be possible to just straight up go for a targeted analysis or an exome sequencing. A third one is a neonate with transposition and hypospadias, but we noticed this earlobe on the clinical examination. I don't know if anyone happens to have an idea of the diagnosis. So in this case, we are in the syndromic form, given the case of dysmorphic features. Then you have to always think about syndromic forms. I noticed as well in the presentations you did yesterday that the syndromic features were described as absent, which makes me very happy as a geneticist that you think about the possibility of a syndromic underlying cause, because then we may have to expand our diagnostic approach with broader West-based panels. In this case, this is a diagnosis of Mowat-Wilson syndrome caused by heterozygous variant in the ZAP2 gene, and they have this very typical upturned earlobe with a central dimple that can give away the diagnosis. I want to move on with another syndromic case. This is a prenatal polymalformation where there was a female genitalia seen with an XY karyotype on the NIPT. There was a complex heart defect. There was neural tube defects, corpus callosum agenesis, kidney problems, limb malformation, and then postnatally I could see the hypertelorism, and an autopsy did not show any Mullerian structures, and the gonads were confirmed to be testis. So again, diagnosis, this is a syndromic case where we opted for a whole exome sequencing and a CNV analysis. The exome sequencing could not reveal any variants, and the CNV analysis showed a duplication again of the ZAP2 gene of exon 1 and 2. So I want to remind you again of the limitations of exome sequencing. Sometimes we can miss duplications, deletions. Going back to the data, we could indeed see the duplications were suggestive in the exome data, but sometimes it's difficult to see if you don't know exactly where you have to look at. But then the question arises again, is this normal variation or is this causal? Because if there's duplication, so again, if it's in tandem, so right next to each other, it can disrupt the normal gene product, but if it's somewhere else in the genome, then it's not the cause. So again, to try and resolve this variant, we can perform segregation. This variant was not present in the parents, which is an argument for pathogenicity, and we can correlate with literature and with the clinical presentation. So these are the features that we can see in Mowat-Wilson on the right. On the left are the signs that we also had in our case to save some time. So all of the features indeed can be seen in Moat-Wilson syndrome. Just the neural tube defects are not very common, but there are some case reports. And also I found another case that described a duplication of the first 2 exons of the ZEP2 gene. So this makes me pretty confident that this is the cause, but still we cannot be 100% certain if we do not know whether this duplication is right next to it or somewhere else. And that is also a limitation of exome sequencing that we call a problem with phasing, is that we do not, in short and simplified, that we do not always know where in the genome we are looking at. If we have a sequence, we do not always know where in the genome that sequence originates from. And that's also the problem with the CYP21A2 gene. If we find a variant, we do not know if it is in the inactive copy, the pseudogene, or in the active CYP21A2 gene. And that's a problem of conventionally used short-read whole genome sequencing, is we cannot know always where it is originating. And that's where this last box in the pathway comes in. Everything above it is what we use in conventional diagnostic, but this last one is more used in research setting. And the way we can try and solve this phasing problem is with long-read whole genome sequencing. And I want to try and explain a little bit before we go further. So how conventional exome sequencing is done is short read. So we fragment the DNA and we get very short fragments. And from each fragment, we determine the sequence. So for example, on the top here, we have a DNA sequence, and the red boxes represent 2 identical or almost identical regions. So if we fragment the DNA, we get several fragments, sometimes overlapping. And if we, for example, look at the blue reads, they will be both the same left and right. They belong to the red box of the repetitive region. But if we would find a variant in one of those blue reads, we wouldn't actually know in which of the 2 red boxes that variant is actually in the genome. That's the problem of phasing. And that is what long-read sequencing solves. We have longer reads, so we have information before and after the repetitive region, and that way, if there is a variant in one of these red long reads, we know exactly where it is in the genome. And that is something that long-read sequencing can solve. The same with CYP21A2 gene. We know exactly if it's in the pseudo gene or in the active copy, because we have that information before and after that repetitive region. Long-read sequencing also solves another issue, and this is again the same slide from yesterday, where I explained that short-read whole exome sequencing can only detect nucleotides or a few nucleotides, whereas CNV analysis is up from 100,000 nucleotides. So there's a big gap in between, a gap that we are missing of variants that might be present. And I want to illustrate that with another case. This is again a syndromic form where there was penoscrotal hypospadias with undescended testis. AMH was in normal male range, but there was Hirschsprung, corpus callosum agenesis, kidney problems, and pulmonary stenosis. So again, syndromic case. And in the diagnostic workup, short-read exome sequencing that we use in diagnostic was normal. CNV analysis was normal as well. But luckily we did karyotyping, which showed a translocation between chromosome 2, where you can see here a shorter chromosome 2, and the longer chromosome 21. So this prompted us to take this case into research setting and do a long-read whole genome sequencing. And this revealed a very complex rearrangement where there were 11 deletions, 6 inversions, and 8 translocations, not between 2 but 3 chromosomes, totaling 23 breakpoints. So I want to emphasize that 11 deletions were all missed by the conventional techniques that we use today in diagnostics. And if you can see, the smallest one was 50 bases and the largest one was 25 kb. So this is all within that gap that we are missing with current diagnostic techniques. We also missed 6 inversions. This is also something we know we miss with short-read sequencing, because the sequence is the same, is just the other way around. So this is again a problem of phasing. We can sequence the region, but the reads are too short to know what comes before or after it, to know that it's inverted. Same with translocation. The information is still there, just on a different part of the genome, and the short root sequencing, we don't have that information to know where in the genome we are looking at. So all of these things were missed with short root sequencing. And if we want to then try to put this together, and this was the work of a bioinformatician of ours, this is, here you can see the normal chromosomes, chromosome 2, 5, and 21, the ones that were involved in this complex rearrangement, where the gray areas were the ones that were deleted, also some very small ones, because this is on scale. And then you can try and map how the genome of the patient was using a subway plot. So for example, the DNA of the patient starts from region 2A, and then suddenly it goes to region 2O in an inverted way, going back to chromosome 21. And that way you can see that there were 11 deletions, and here the chromosomes that ended up being with the different colors in representing different chromosomes to really reveal this very complex structure that was completely missed. So it's getting a little complex at this point. It's, if your head hurts, that's okay. Mine does too a little bit when I see this. It's just to illustrate that there are very complex rearrangements that we can miss with just the techniques we use today. And then, of course, can we find our diagnosis? And hold and behold, there's again the ZAP2 gene here as well. And this is again a case of Mowat-Wilson syndrome that could be solved. So again, the slide from yesterday, to be careful about the limitations of exome sequencing. We can miss deletions and duplications, as we just saw. The pseudogene of CYP21A2 is always a problem. And then the last one, which I did not touch upon yet, are the non-coding variants. So of course, with exome sequencing, we only sequence the exons, the coding part. We don't sequence the 98%, the other 98% of the genome, which is the non-coding part. And there's also a lot of variation. And a common, or well, the most studied maybe non-coding region for DSD is the SOX9 region. Just to illustrate, so there are enhancers and promoters that are before the gene, and if the enhancer is connected with the promoter, then it activates the transcription. So the promoter and enhancer are not transcribed to protein, but it regulates the transcription of the gene. So it tells it how much, when the protein needs to be formed. So, and usually in XY individuals, there is an SRY present, which is a transcription factor that allows binding of the enhancer to the promoter, and then transcription is activated of SOX9, initiating the male sex determination. In XX individuals, this is usually not the case, where you do not have SRY gene, and therefore no active transcription. But there are situations where there is a duplication of the enhancer, which makes it potent enough to be able to activate transcription even in the absence of SRY. And then you can also have a DSD. So long-read sequencing, long-read whole genome sequencing is able, in theory, to detect any genomic defect, but it is not able to diagnose every DSD patients. We still have to take into consideration that some forms are not purely genetic. They are also multifactorial disorders, where there's a combination of genetic and environmental factors. For example, small for gestational age is a risk factor for individualization. And for these inheritance patterns, it's still unclear what all the individual factors are. So today we focus on the monogenic forms, and we focus on the ones with the highest probability of being monogenic. That's why usually syndromic forms are selected, because they have a higher probability that one genetic defect is the underlying cause. So also for DSD, and what we focus on in research is we focus on those patients with complete gonadal dysgenesis, with parental consanguinity, for example, or if multiple family members are affected. Those are the cases we can move towards that last box, towards the research setting where we try and find the cause with whole genome sequencing for the non-coding part, or long read to detect those structural variants that can be missed. So, and that is how we try to get a genetic diagnosis in DSD. Thank you.
Thank you so much, Dr. Siren. We'll keep the questions till the end for the Q&A session. Thank you so much.
So now we'll move to our next session, which is titled DSD from Sharia Perspective, or Religious Perspective for non-Arab speaking people here. So it will be presented by Dr. Bassam Shatti. We want to welcome him to the stage. And we'll also have 20 minutes for the talk. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening for all. بسم الله والحمد لله والصلاة والسلام على رسول الله وبعد. احنا عندنا بالنسبة للموضوع حول المعايير الشرعية لتصحيح الجنس من المواليد ذوي الاشتباه الجنسي. الحقيقة أنا مع أخواني وأخواتي في هذا المجال صار لنا أكثر من 18 سنة تقريبا، وواجهنا أكثر من 32 حالة، وفضل الله سبحانه وتعالى استطعنا أن نخرج بأمور عظيمة ومرضية لدى الجميع. أولا كنا نعرف بأن ديننا الإسلامي هو دين كامل، كما ذكر الله تبارك وتعالى: اليوم أكملت لكم دينكم وأتممت عليكم نعمتي ورضيت لكم الإسلام دينا. وكذلك الله تبارك وتعالى قال تبيانا لكل شيء، وقال كل شيء فصلناه تفصيلا. فالله عز وجل ما ترك شيء إلا وبينه سبحانه وتعالى، إما أن يكون في القرآن أو في السنة أو في سنة النبي صلى الله عليه وسلم وأثار الصحابة رضي الله عنهم. ومثل هذه المجالات أصلا هي قديمة وليست حديثة، وبالتالي الله سبحانه وتعالى جعل الحلول وأمرنا بالتداوي. فلذلك نجد أن النبي صلى الله عليه وسلم يقول: ما أنزل الله من داء إلا وأنزل معه دواء، علمه من علمه وجهله من جهله. وبالتالي احنا نعتقد أن الله تبارك وتعالى بلا شك خلق آدم وخلق من آدم حواء وبث منهما رجالا كثيرا ونساء. فالله عز وجل جعل الذكر والأنثى، وأي طارئ يكون هو مرض لا بد أن يتم علاجه بهذه الصورة. وبالتالي الله سبحانه وتعالى حدد لنا هذه التحديدات الواضحة في هذا المجال. إيه إن شاء الله. أنا أعتقد أن هذا الإنجليزي مترجم يعني. إيه.
سوري.
مترجم، أول شيء عربي وتحت إنجليزي.
أوكي.
إيه.
فالإنجليش راح يطلع ولا؟
إيه راح يطلع. إيه على طول.
لأنه سريع.
إيه خلاص صحيح إن شاء الله. نحاول نبطأ إن شاء الله.
أوكي شكرا. أو إذا تحب أقرأ
لا أنا حاطة، وبعدين أي واحد له الحرية. أنا البحث موجود اللي يحب ينقله، وكذلك الورقة اللي أنا قدمتها باللغة الإنجليزية والعربية، فاللي يحب ياخذه بعد هذا موجود يعني.
طيب. So Dr. Bassam is a professor of Sharia, which is a religious studies at Kuwait University, and he has prepared the slides in English and Arabic, and he will be sending the slides for you so that you can reflect on the English section. And He will speak in Arabic. He's been working with us as DSD for the past 20 years. So he has been also working up the cases together from the religious point of view when we sit in the DSD committees for more than 32 cases. He is there and he is a member of our DSD committee. So he'll go through with his presentation in Arabic, and there will be translation in English in the slides, and you will be given a copy of the slides.
ماشي.
شكرا.
فالشاهد أن الله تبارك وتعالى خلق السلالة إما أن يكون ذكر أو أنثى. أما أن يحدث أن هناك إشكال أو اضطراب فهذا أمر طارئ ويحتاج إلى علاج. ومن رحمة الله عز وجل جعل هذا المرض لا يمكن أن يخرج به رأي طبيب واحد، فلا بد أن يكون مجموعة من الأطباء. ومن رحمة الله عز وجل أن جعل هناك 7 أيام ممكن أن تراجع هذا المريض حتى يبين إن كان ذكر أو أنثى، ويكون هناك فحص شامل. إذا ما نفع 7 أيام يكون 14 يوم، ما نفع 14 يوم يكون 21 يوم. هذه ليست فقط في العقيقة، لا حتى في التسمية، وجعلها الله سبحانه وتعالى وفوق كل ذي علم علم. كذلك ظاهر أن يبي له شوي النقلة هذه شوي، لأن الظاهر قاعد يطلع بالإنجليزي. ماشي طيب ماشي. وبالتالي احنا ليش احنا نتكلم عن قضية اللي هو الذكر والأنثى؟ لأن هناك في أحكام شرعية تختلف عن الذكر والأنثى. فبالتالي مثلا قضية النكاح يكون إيجاب وقبول، والزوج هو مسؤول عن هذا. كذلك قضية الشهادة، شهادة المرأة وشهادة الرجل. كذلك يكون في قضية الميراث والوصية. كذلك قضية الولاية. فكل هذه الحقيقة فيها يعني أسئلة دقيقة في هذا الشأن: النكاح والمواريث والخلوة والمعاشرة والولاية والإمامة، إمامة المسجد وإمامة المسلمين، وكذلك اللي هو الشهادة. أيضا عندنا في قضية اللي هي الله سبحانه وتعالى جعل مثل هذه الأحكام في أمور. أول ما حدث مع علي بن أبي طالب رضي الله عنه، فنجد أن علي بن أبي طالب أول ما تكلم في هذا الموضوع لما أصبح هناك في الخنثى، وبالتالي أصبح هذه المسألة خطيرة. فجمع الصحابة رضي الله عنهم، قال: ننظر إلى مكان البول، فإذا كان عنده جهازين ينظر إلى مكان البول، فإذا بال مثلا من أحدهما أو أولهما خلاص يكون هذا ذكر، أو إن أنثى إذا كان من آلة الأنثى أو آلة الذكر. ثم بعد ذلك إذا بال من كلا الطرفين ينظر أيهما أنقى، إذا كان يعني كلاهما نقي ينظر إلى الكثرة والقوة في هذا الشأن، حتى يعني يشمل فيها الأمور التي بينها الشارع الحكيم. طيب، ثم ذلك اللي هو تحديث الأحكام في مثل هذا الموضوع، أن المرأة أحيانا يعني هناك في أدلة واضحة المعالم. الإسلام ينظر في النقطة الثانية، إذا البول لم يكن واضحا ينظر فيه بعد ذلك إلى إذا كبرت هذه مثلا ينظر إلى البلوغ، وكذلك الحيض وقوة الإنجاب، معطيات الجينية والوظيفية، وكذلك أن يكون هناك الخيار الطبي بالنسبة للتعديل. لكن الإسلام أمرنا أن لا يكون هناك التعديل الذي يأتي إلى تغيير خلق الله عز وجل، لكن التعديل الذي يتوافق مع السنة التي جعلها النبي صلى الله عليه وسلم. فهناك أجر للطبيب، أجران: أجر دنيوي وأجر أخروي إذا هو عالج مثل هذا المرض. لكن التدخل بحيث أن نغير هذا الكيان من ذكر إلى أنثى، الحقيقة هذا مخالف لهدي النبي صلى الله عليه وسلم. بالتالي لا بد أن ينظر في هذا الموضوع. كذلك قد تكون هناك يعني بعض الأطباء، أنا حقيقة لما شفنا 32 حالة اللي مرت علينا وجدنا أغلبها أثناء الولادة، فالأب والأم يعني يركزون على هذه القضية، هل هذا ذكر ولا هذا أنثى، وبالتالي يعني أصبحت هناك المشكلة الاجتماعية، وما عاد أصبح ينقل أو يرضى هذا الأب. فعليها لا بد أن يعني ينظر في هذا بعين الاعتبار. أيضا يؤخذ الوقت الكافي، يعني حقيقة من ال 32 حالة مرت علينا 4 حالات لما وصلوا إلى سن البلوغ وتغير صوت البنت وأصبح مثل صوت الرجل، فهنالك أصبح يعني الناس تعايرها وكذا وكذا، فتم التغيير في هذا الأساس. لكن بعضهم أيضا غير مقتنع إن ليش أنتم تريدون أن تغيرون مثل هذا يعني ما يحدث لهؤلاء الأبناء. أيضا إخواني وأخواتي اللي هو أول شيء نقنع الأهل لا تحسبوه شر لكم بل هو خير لكم، لأن الله عز وجل لا يقدر الشر المحض، فالله سبحانه وتعالى ما جعل ذلك إلا لتقدير الخير الذي يتم. فإذا عندنا اللي هو ذكرنا عن علي بن أبي طالب، وكذلك ينظر في قضية أحيانا يكون تحت البطن، وشفنا الحالات يكون الخصيتين في مكان وربما الرحم في مكان وكذلك قناة فالو في مكان آخر، فبالتالي أو المبايض، فيحتاج إلى النظر في هذه المسألة. الإسلام يهتم اهتمام بالغا في أننا نراعي عدة جوانب. الجانب الأول هو هل يكون هناك يعني الحمل والرضاع ولا لا، لأن النبي صلى الله عليه وسلم يأمرنا قال تزوجوا الودود الولود فإني مكاثر بكم الأمم يوم القيامة. في الحقيقة احنا ننظر إلى أن كيف نجعل هذه الوسيلة أن المرأة تحمل وكذلك الولد أو الذكر أن يكون هناك في إنتاج لمثل هذه المسألة. كذلك حديث النبي صلى الله عليه وسلم والقاعدة الفقهية الضرر يزال، يعني نبذل قصارى الجهد حتى يزال، ولكن ننظر إلى العملية. هل العملية هذه مكلفة بالنسبة ومتعبة ويترتب عليها أمور كثيرة، وهذا حقيقة ضرر خطير جدا. كذلك الإسلام أمرنا أن إذا تساوت الأمور ننظر إلى هذا الأب، هل هو عنده بنات مثلا ويحتاج إلى هذا، وفي النهاية لا هذه راح تحمل ولا هذا راح يكون له إنجاب، فممكن أن يدخل فيها مراعاة الحالة النفسية التي يكون عندها هذا لا. لكن التحويل يعني يكون محرم إذا احنا خالفنا فيه أمر الشريعة الإسلامية. ثم بعد ذلك يعني ننظر في الأسباب الوراثية وكذلك إزالة جميع الشبهات. فأحيانا يكون الواحد الأطباء عندهم بعض الشبهات، يعني ما يمنع أن احنا نستخدم مثل هذه الهرمونات وكذا، لكن باعتدال، لأن هذه الهرمونات لها إيجابياتها ولها سلبياتها. ولذلك يقول النبي صلى الله عليه وسلم الطبيب ضامن. الطبيب ضامن يعني لا يقطع مثلا جزء من الذكر أو الأنثى ويترتب عليه المساوئ قبل أن يكون هناك مشورة جماعية والأخذ في هذا الموقف. ثم بعد ذلك يعني كما ذكر الله عز وجل فلما تغشاها حملت حملا خفيفا، بمعنى ننظر إلى قضية الحمل في هذه المسائل. كذلك هناك علامات تظهر في سن البلوغ، الخشونة أو نعومة الصوت وتوزيع الشعر، الإبط، العانة، اللحية، الشارب كذا، فيؤخذ هذا في عين الاعتبار. كذلك لما يكون هناك المهبل والحب منوي والبروستاتا، وأيضا ينظر في حال هل أيهما مكتمل أكثر اللي هو العضو الذكري أو كذلك الآلة الأنثوية. أيضا نحرص احنا في دولة قانون، يعني الآن الحمد لله احنا أعطينا تقريبا شهادتين في هذه اللجان وتم تغيير هذا الجنس قانونا، وهذا اعتراف وهذه قوة لهذه اللجنة لما تكون بمثل هذه الجوانب. أيضا اللجنة الحمد لله دخلت اللي هو عالم أو دكتور في علم النفس وكذلك علم الاجتماع حتى يكون هناك محاورة وإقناع، لأن في العالم يحدث هناك اكتئاب وربما انتحار، ولكن الحمد لله احنا في الكويت ما حدث مثل هذا الانتحار وكذلك الاكتئاب، واحنا معاهم. يعني الأب يريد أن يسأل، الأم تريد أن تسأل، هذا الطفل لما يكبر ممكن أن يسأل. الآن في توجه عالمي أن أنت دع هذا وبعدين هو لما يكبر يختار، وهذا خطأ كبير جدا. لا بد أن يعالج ولا نؤخر العلاج عن هؤلاء المرضى حتى يكون الدقة المتناهية، لأن الله سبحانه وتعالى أمرنا أن نعالج بقدر الاستطاعة، والله يقول تعاونوا على البر والتقوى ولا تعاونوا على الإثم والعدوان. هنا الحقيقة الحذر من الخطأ في استعجال قطع أو إزالة العضو الأساسي في المولود، فلا بد من التأني ودراسة فرق طبية حتى يكون القرار صحيحا في هذا. أنا شوي أوقف عند الإنجليزي بس عشان الأخوة أو الضيوف الكرام يشوفونه شوي. وكذلك لا يجوز لأي طبيب أن يمتنع عن العلاج. بعضهم يقول هذه مسؤولية وأنا حقيقة أخاف من القانون وأخاف من الأهل وكذا. حقيقة إحنا لابد أن أنا ودي نحطها ضمن توصيات أن لابد أن نوجد قانون يحمي الطبيب، وبالتالي يبذل قصارى الجهد. وكذلك أغلب الحالات اللي 32 حالة منهم 12 حالة ولادة في المستشفيات الخاصة، والمستشفيات الخاصة للأسف أن همها هو تبشر الأب على حساب هذا الطفل وكذلك مستقبله. كذلك دور الطبيب في الكشف عن حقيقة الخلق، الاختيار الأنسب في التعايش، بمعنى أن نشوف هل هذا ممكن تعايش بهذه الصورة بعد ما نأخذ جميع هذه البنود وننظر في التركيب والغدة وغيرها. أيضا هناك الحقيقة الشيء الذي ودنا أن نذكره هو أن الله سبحانه وتعالى جعل المدة الكافية، فليش إحنا نستعجل قبل أن نأخذ المدة الكافية ونستفيد من الآخرين، وفوق كل ذي علم عليم. بعد ذلك أنا حقيقة ودي أن هذه تضاف اللي هي كتوصية، أن نطلع هذه التوصية ضمن المؤتمر التأكد من سلامة تحديد جنس هذا المريض وتسميته، ونأخذ 7 أيام 14 يوم 21 يوم حسب ما ذكر النبي صلى الله عليه وسلم في الحديث الذي رواه أبو داود وكذلك الترمذي. وأيضا لا بد أن نوجد قانون يحمي هذا الطبيب ويأخذ هذه المدة الكافية، وأن يكون هناك توعية. أنا حقيقة بحكم أني عضو في الإفتاء وطرحنا مثل هذا الموضوع، هل واجب علينا أن نخبر الأبوين من الولادة فورا بأن هذا ذكر أو أنثى؟ الجواب لا. وكذلك الآن أنا في إعداد خطبة الجمعة نائب الرئيس، وأيضا حطينا خطب تتكلم عن هذا الموضوع، وأيضا عندي برامج توعوية وأيضا تكلمنا في هذا الموضوع. أيضا حتى الأبحاث في مجلة الشريعة وضعنا أن قضية الإعطاء المدة الكافية ولا بد أن يكون هناك توعية. آخر حالة وجهناها اللي هي بنت عمرها 13 سنة وبالتالي اقتنعت أن هي ذكر وبالتالي تحتاج إلى بعض العمليات وكذا، وكان تقول أنا خلاص راح أنتقل إلى مدرسة ثانية وإلى منطقة ثانية، وحتى يتم هذه بالصورة الكاملة. ونسأل الله سبحانه وتعالى التوفيق والسداد للجميع، وسامحونا، ونسأل الله سبحانه وتعالى التوفيق لكم جميعا، وأن يكون هذا المؤتمر ناجح. وأنا أشكر جميع المقيمين أو القائمين على هذا المؤتمر، وأشكرهم لاستضافتنا في هذا المؤتمر. والبحث موجود عند الأخوة اللي يحب يأخذ البحث كاملا موجود، وكذلك باللغة العربية موجود، والمترجم أيضا موجود. جزاكم الله خير. السلام عليكم ورحمة الله.
Jazakallah, Dr. Bassam. Now, our third session in our third lecture in this session, it gives me great pleasure to reintroduce again Professor Martine Kool's. She will talk. She's a professor of pediatrics and she's a pediatric endocrinologist at Ghent University in Belgium. She will be talking to us about an update on the clinical approach to girls with complete androgen insensitivity. The floor is yours, Doctor. Have 20 minutes.
Okay. So, hello again, everyone. So I will tell you something about clinical management, or give you an update at least on the clinical management of androgen insensitivity syndrome, as well as discussing briefly Mayer-Rokitansky syndrome. And androgen insensitivity and also Mayer-Rokitansky are actually conditions with many phases. AIS can present as complete and partial and even minimal AIS. Mayer-Rokitansky, there are two types described, an isolated form as well as a more complex form in which can be renal anomalies, most frequently unilateral renal agenesis. There can be vertebral and skeletal anomalies like rib aplasia and scoliosis. Hearing loss and cardiac anomalies are less frequent, but they occur in around 5% or a little bit less in girls with Mayer-Rokitansky. Importantly, those two conditions may present exactly in the same way. And the most typical is, for example, a girl 15 years old who is consulting for the absence of menses. Pediatric endocrinologists have a long differential diagnosis list when a girl is presenting with absence of menses, but one of the key messages that I would like to give here is that just with the simple clinical question and also investigation, if there is breast development, you can already come a long way, because you can exclude almost all the differential diagnoses apart from Mayer-Rokitansky and androgen insensitivity. Primary ovarian insufficiency, sometimes the puberty starts spontaneously and it stops somewhere halfway, but if there is full breast development, simple additional tests like hormones, karyotype, and an MRI, you can discriminate between the two remaining conditions. In complete androgen insensitivity, there is breast development, there is an important elevation of testosterone, the karyotype is 46XY, and it is a very unfrequent condition actually. Mayer-Rokitansky, much more frequent, 1 in 4,000 women has this condition. In this condition there is also breast development, but this time the hormones are normal and the karyotype is XX. So all in all, quite easy diagnosis. However, if we are suspecting androgen insensitivity syndrome and we perform sequencing of the androgen receptor gene, this will give us a clear molecular genetic diagnosis in 90% of individuals with complete AIS, but only 20% of individuals with partial AIS. So it means that there can be decreased androgen signaling without a mutation in the androgen receptor gene. And what can you do then to further confirm the diagnosis? Well, there exists an in vitro test that can look at the way of androgen signaling. This is a test that is done on genital skin fibroblasts. So if these are available, you can send them, for example, to this lab in Kiel. And they have identified, I don't know if I can use the pointer, they have identified a group of individuals with a phenotype of androgen insensitivity, but without a mutation in the gene. And how can what can be the cause in these circumstances? They have identified some patients who have hypermethylation of the androgen receptor promoter, and thus this results in decreased androgen receptor mRNA and protein. Moreover, they have discovered also other causes of this situation. For example, a mutation in a non-coding part of the gene. This can be investigated by whole genome sequencing and long-read sequencing. And very recently, they have also discovered the first androgen receptor cofactors. This is the DAM2 gene and protein, and it is actually required to assemble the androgen receptor as a polymer because it cannot action as a monomer, together also with the polymerase II enzyme, and all this complex is necessary for correct androgen signaling. If there is a mutation in this DAM2 gene, this can give rise to a phenotype corresponding to partial AIS. For Mayer-Rokitansky, most cases appear isolated. However, familial recurrence has been reported, so this has led to the suggestion that at least some genetic factors are involved. Some promising copy number variants have been identified involving specific genes, and also there are promising sequence variants in, for example, GREB1L gene, PAX8, HNF1B, and Wnt4. And Wnt4 has been associated associated also with hyperandrogenism in women with Mayer-Rokitansky, and this is called the Circle syndrome. But the most important message that I would like to give is, if you have diagnosed a girl with Mayer-Rokitansky, she needs some further workup, at least a renal ultrasound and also an X-ray of the cervicothoracic vertebrae in the rib. And if you really want to ensure that she has no cardiac defect or hearing loss, then you also need to investigate this. So usually, if a girl gets this diagnosis, they need some additional workup, and of course, they need to see a psychologist. Then I will briefly discuss hormone replacement therapy in women who have complete AIS. Of course, this is only needed after gonadectomy. Women who do not have a gonadectomy, they produce a lot of testosterone. This cannot act, but it is converted in the body to estradiol, and they have normal estradiol levels. So it's very important for their breast development, for their quality of life, for their bone health. So it has very, very good effects. The aims of hormone replacement therapy are to maintain female secondary sex characteristics, to prevent bone loss, prevent neurocognitive disorders, and promote cardiovascular health. Importantly, many women get quite low doses of 17-beta estradiol. Very often, they are given only 2 milligrams, in which you reach only low levels of estradiol, which are not similar to typical women who usually have quite higher levels. So usually, to have physiological levels of estradiol in the in the high normal reference range, you need a doses of 4 milligrams of 17-beta estradiol orally. You can also use gels, for example, or patches. Progestins are not needed in the condition, as these women do not have a uterus. But many women, when they have gonadectomy, for example, at later ages, they say that when they are switched then to estrogen supplementation, they feel that it is suboptimal as compared to their previous endogenous testosterone production. They suffer from fatigue, hot flashes, mood swings, and decrease in sexual functioning and psychological well-being. So this led Olaf Hiort, who's a pediatric endocrinologist working in Lübeck in Germany, to the question whether it's not more physiological for them to supplement them with testosterone, as this is their biological source of estrogens. And so he did a double-blind crossover study, placebo-controlled, and women were taking testosterone and then estradiol, or the other way around. This was investigated. What were the outcome measures, the mental health-related quality of life, psychological well-being, sexual function, and some somatic effects. And what he found was actually that with testosterone or with estradiol, all the outcomes were similar, except for sexual desire, where testosterone outperformed estradiol. So at least from this study, even if it doesn't clearly tell us what to do exactly, we know that also testosterone supplementation is a safe alternative and might be perhaps better in women with reduced sexual functioning, if they would accept it, of course. Whether it has also effects on bone mineralization, body composition, metabolic profile, this requires further study. This brings us to the topic of bone health in AIS. There are only very few studies with limited and poor quality data on bone health in adults with complete AIS who had gonadectomy, and for those who did not have gonadectomy, there are actually very, very little data. However, thinking about the dual effects of both testosterone and estradiol on the bones, it is very likely that bone health is a problem, might be a problem in women with AIS, as they only have estrogen action and not testosterone action. And in all women, in all human beings, both testosterone and estradiol are very important for bone health and bone remodeling. The only study that I could find that says something about this is this study from Italy, 32 women with complete AIS. and also 32 controls, and all these women had gonadectomy, but again with very low substitution doses. Over 50% of them had trabecular and cortical osteopenia, osteoporosis also. The trabecular bone is also always more vulnerable than the cortical bone. Transdermal estradiol in this study had better results than oral estradiol, but probably again this is due to the low doses that are usually given, especially with oral supplementation. And then a somewhat difficult topic for many people, gonadal management. Historically, of course, gonadectomy was performed in all individuals with a Y chromosome and a DSD condition. Of course, this is not the case nowadays anymore. We know that there are different conditions with different risks, so we can come to a kind of risk stratification. And this is a simplified scheme, actually, that tells us that if you have a DSD condition with gonadal dysgenesis, so where the gonad has not well developed into a testis or an ovary, there is a very high chance for cancer development and also a very low function of the gonad. Usually it doesn't produce any hormones. But in AIS, for example, the situation is very different. The gonad has developed into a fully functional testis, which produces large amounts of hormones, a huge amount of testosterone and anti-Müllerian hormone. It's a very functional organ. It has fully developed as a testis, but the problem is that the testosterone cannot work, and therefore this causes damage to the germ cells. But this damage induces a much lower cancer risk as the situation where the gonad has not developed as a testis. And the same is true for testosterone biosynthesis disorders. In addition, as I explained you, the testosterone production is very important for women with complete AIS as it is converted to estradiol. So this means that it's a logic action to perform gonadectomy in high-risk situations where there is high risk and no function of the gonad, and to evolve to design a kind of surveillance protocol in individuals who have a low risk and a high function. Nonetheless, we did a survey in 2018, not so long ago, showing that there is a huge variation in reality in practice. So some centers perform gonadectomy before puberty, some do it after puberty, some do it only on indication. In partial AIS, the situation is even more dispersed. So we really need standardized management, I think. Still, we should also take into account that an invasive cancer is not something that appears all of a sudden. It takes many, many years to develop, and you have many chances already before that to investigate the gonads and to see whether there is some predisposition for cancer development. The first damage is maturation delay of the germ cells. This evolves towards a pre-germ cell neoplasia in situ, and then again a germ cell neoplasia in situ. So still in situ lesions. These are not dangerous. They will not cause cancer. They will not need treatment as such. The most important question is how often does it occur that a pre-neoplastic lesion turns into an invasive lesion? And that is somewhat difficult to know, but if we look at the literature, at all published cases, which we did some years ago, we found that looking at 456 published cases, that a pre-germ cell neoplasia in situ, so not the dangerous lesion, occurred in 6.4%, and that invasive germ cell cancer was only seen in 1.3% of women, which are all at adult age. So I think you would agree with me that doing a prophylactic gonadectomy for a condition that occurs only in a little bit more than 1%, you don't remove an organ for such a low risk. For men with partial AIS, data are much more limited, I think we need more research there, collaborative research, because it is very difficult. But from the 26 men that were really published, there were not a single case in who there was appearance of any in situ neoplastic lesion or an invasive tumor. So What can we do now? I think it is clear that no routine gonadectomy should be done as a first-line approach. What we believe is meaningful is that we discuss the alternative of careful surveillance as an alternative for gonadectomy in adolescent or young adult women with complete AIS. I told you that no cancers occur in children, so there is no need to remove the gonads at early age. And when this woman is 18 years old, she's old enough to understand and to decide for herself whether she wants to take the risk, whether she wants to engage in a surveillance program which consists of an annual MRI, also with serum biomarkers. Although we need to tell her that even with this very close surveillance, we are unable to detect in situ neoplastic lesions. They will not be visible on MRI. You will not detect them by the biomarkers. You will only be able to detect an invasive cancer. So that is the reason why we need to make sure that they will come back every year. Also for men with partial AIS, we propose kind of similar protocol with an annual ultrasound and with a biopsy at the end of puberty. So again, this is a situation where shared decision-making with the young adult person is very important in our view. We've published this, I displayed the reference, and this is also repeated actually in this GCM paper that that Hannes has already shown. Of course, there are many children with complete AIS who have labioscrotal or inguinal gonads. Usually we move them at the entrance of the inguinal canal, where we can easily image them by MRI, for example, and should there be surgery needed, at least we know where they are. And then after puberty, they usually engage in this surveillance protocol. From the girls with complete AIS, I think there have been about 20 with whom we have proposed either gonadectomy or this surveillance. All 20 have chosen to do the surveillance protocol. Vaginal dilation, I will touch only very briefly because we have, or Birgit has discussed this a lot. I think it's the first-line choice, has been identified also by the American College of Obstetrics and Gynecology. It leaves no scars, it has no side effects, but you need a psychologist and a physiotherapist for support, because this gives you much better outcomes. Also, and Birgit also touched on that, there is no need for hurry for this therapy, because many girls experience sexual intimacy prior to therapy. And so, the worst motivation actually to do this is that, for example, someone of her parents says, you need to be ready for, I don't know what, but anyway, that's the worst motivation. The best motivation is the girl who says, I want this myself. We have seen that if you, then it only, like Birgit also explained, there's only one chance you have to do this vaginal dilation. So if you do it at the wrong time point, you will be lost. So Birgit explained about the team and the role of these various persons. This is again the brochure of, again, best moment is when they were ready, when they were motivated, and the poorest results were in girls less than 16 years old. There were 2 of these girls and they both stopped because they had no motivation. From this study, we learned that probably maintenance dilation is probably not needed after surgery, but actually there are very, very little data about it. Partial androgen insensitivity syndrome is an even more difficult condition. Decision on the sex of rearing can be extremely difficult, especially in individuals who have a low score, external genitalia score at birth. Many girls, for girls, we have a lot of questions like what is the impact of living with these atypical genitalia and eventually labial testis? To what extent will virilization occur in puberty? If it's strong partial AIS with some remaining activity, well, then there will be virilization. But if it's just mild clitoris hypertrophy at birth, will this induce virilization at puberty? We don't know. And we discussed the problem of gonadectomy for cancer risk, but here the additional problem is, do I need this gonadectomy to avoid virilization? In boys, the problems are also manifold. So be aware that if you raise a child as a boy, there will also be a lot of difficulties. There will be very poor penile growth. 100% of them will develop important gynecomastia. This all will have a very high psychological impact. All these boys require mastectomy. The hypospadia surgery is often much more complex and needs multiple re-interventions with often very poor results. Fertility is very, very unlikely. There are only some cases described after ICSI, but it's very unlikely. You can support the virilization with testosterone or DHT, but testosterone will be converted to estradiol again. You can try DHT because it's non-aromatizable, but it also has very little effect. I have tried in 2 boys with an aromatase inhibitor, which inhibits the conversion of testosterone to estradiol, so it gives sky-high testosterone levels in these boys. It is very effective in avoiding breast development. However, it came with a lot of questions. How long do I have to continue? What will happen if I stop this? What about the germ cell cancer risk? This very, very active testis. How will they support this? And so on. Well, then the question of fertility preservation. Many individuals with both AIS and MRKH want to have children. It's the most important burden for them is infertility. As I said, impartial AIS offspring is extremely rare. Current options could be testicular semen extraction, but this requires, of course, mature sperm, which is impossible in AIS. Testicular tissue cryopreservation for in vitro maturation of germ cells, for spermatogonial stem cell transplantation, or for autografting of testicular tissue. They have all been described, but all these techniques result in massive loss of remaining germ cells. And already in AIS there are almost no germ cells left, so you can be sure that it will not work in AIS. In addition, as I said, only very few germ cells remain. Why do they remain? Why do they survive? They are equipped with abnormal characteristics of survival, of proliferation. Is it these germ cells that you want to use to create offspring? Well, I think we need to reflect on that. It also has a very high cost. In addition, you also need a female partner, donor egg, gestational carrier, and so on. Last slide, uterus transplantation for women with Mayer-Rokitansky. Almost all uterus transplantations that have been done so far have been for this specific indication. In 2014, there was the first live birth of a baby following uterus transplantation. Currently, the success rate is 36%. You have no transplantation of fallopian tubes, so IVF procedure will always be required. You can do the first embryo transfer 3 to 12 months after transplantation. The birth is always by cesarean section. There are a lot of complications to this surgery, graft failure in 23% and surgical complications in 17%, mostly iatrogenic, damage to the urinary system. Of course, you need to use immunosuppressive therapy to avoid rejection of the uterus. There are many therapy regimens described. They have a lot of side effects also, but they continue to improve. They are much better now than they used to be. In view of all the genetic background that has been described now for MRKH, the question is, do we need also PGT if we consider this treatment? After the desired number of children has been reached, hysterectomy is needed. This is usually done 1 to 6 years after transplantation. The reason is otherwise you need to continue with this immunosuppressive therapy. And for the future, probably bioengineered uterus will be used much more because this avoids the need for immunosuppression and there is no shortage of donor tissue. So to conclude, key learning points from this lecture were that AIS results from loss of signaling through the androgen receptor and not only from mutations in the androgen receptor gene, that girls with Mayer-Rokitansky need additional diagnostic workup, that gonadectomy is not indicated in childhood in AIS and is subject to shared decision-making in adults, and careful surveillance is a very good alternative. Vaginal dilation therapy is a first-line treatment for vaginal hyperplasia. Infertility is the major burden for individuals who have AIS. Patients want to be early and fully informed, and peer support can be very powerful. As you see here, this is a woman with AIS who is also a theater maker, and she made a play around living with a DSD condition, all with actors who all had a DSD condition. Of course, we have a lot of remaining questions. I've touched upon them already during the presentation. Thank you very much for your attention.
Many thanks, Professor. Now we're going to move on for our Q&A session. So we want to invite our speakers, Professor Coles, and then we also want to invite Dr. Siren and Dr. Bassam Shatti. We'll have only 10 minutes, please, for the Q&A session.
Any questions?
Yeah, thank you for the talks, very interesting. I have a question for the first speaker. I guess, Silent. The first case you presented was a 21 female with amenorrhea. So is this the age where she was diagnosed? Or she came with the complaint?
And this was the age where she was referred, yes.
So is this because of the patient present late, or it's because of the system delayed?
I'm actually not sure anymore what the exact reason was that she was late in referral. I actually have no idea anymore, sorry.
Okay, thank you.
دكتور بسام، يعطيك العافية على المحاضرة، قواك الله. بس سؤال دكتور بسام، إن قلتي إن في حالات خاصة، I will say this question in Arabic and then we can translate. إن في حالات خاصة مراعاة الحالة، إن في تحديد الجنس، يعني شنو مراعاة حالة الأهل. يعني هل هذا في مثلا احنا وايد عندنا احنا في مجتمعنا يعني الميراث شيء مهم الصراحة، فهل هذا يعني ان مراعاة ان ما يعني انت يعني تكلمت عنه انه ما عنده صبيان بنات، فهل هذا يعني هل يخلق بعدين انه مشاكل او تكسب ان بهالحالة؟ وشلون ان الشرع الحين يعني ما هو شرعيا يعني ان نعطيهم التكسب هذا؟
احنا سلمكم الله اخذناها بالتدرج، يعني الاصل ان نشوف الى مكان البول وخروج البول من هذه الآلة، بعد ذلك ننظر إلى المفاسد والمصالح. الإسلام ينظر إلى هل هناك في الإنجاب ولا عدم الإنجاب، نشوف الضرر اللي هو على الذكر وكذلك الأنثى، هل هذا الضرر راح يكون عام ولا خاص، وبعد ذلك نشوف ترى حتى العظام، يعني في دول الآن حتى في كتاب النووي للإمام ابن القيم يعني يذكر شيء عظيم جدا، وهو اللي قضية العظام، عظام الرجل يختلف عن عظام المرأة، لكن ربما يعني وفوق كل ذي علم عليم. وبعد ذلك إذا كان هو خلاص يعني لا راح ينجب ولا العملية نفس الشيء، ما نفس الوقت والأضرار ما هي كثيرة وتم تجربته، فيعني الإسلام يرى في بعضهم إنه ممكن هو عنده مثلا خلينا نقول 3 بنات وهذا الولد الوحيد فيؤخذ بهذا. لكن الحقيقة أنا إذا سمحتي لي أنا بذكر مثالين. مثال الأول يعني واحد جاء من الوافدين بلاد الشام، فقلنا له ترى يعني مع اللجنة كلنا، فقلنا ترى أنت الحين حاطة أنثى والولد هذا راح يكون ولد، فقال أنا لا يمكن أن يغير ولا أسمح لكم، وأنا باخذ الولد بعالجه في بلدي. يقول عادات والتقاليد وين ودي وجهي وكذا وكذا والناس راح، فيعني هذا كانت في تصور عنده. كذلك يعني أحيانا اللي هي الأم يعني ما عندها أولاد وكانت تبي هذا ولد لأن الرجل مزوج 3، فتبي هنا تاخذ في قضية الميراث وكذا. فكل خاطبنا اللجنة وبالتالي وجدنا أن هذا يعني مقصود وليس الأمر عرضي، فبالتالي احنا حكمنا على أنه لا ما يصير إذا خلينا نشوف احنا الأضرار وكذا. فهذه تؤخذ بعين الاعتبار لكن بالتدرج في الأسباب والمسببات اللي وضعها الشارع الحكيم.
جواك الله، شكرا.
دكتورة, I have a question here, if you allow me. Dr. Hans, do you go routinely with first conventional chromosomal analysis and then you go to the other test, or it is if needed, if you thought that maybe a deletion is there, you will go back to chromosomal analysis, the conventional one?
So I prefer to have the karyotyping results, but usually, I mean, you can start it both at the same time, but the karyotyping results will already be ready by the time you have the exome analysis, because it's very important to have that information in order to interpret the exome data, because you really need the clinical information.
Still takes 3 weeks
for karyotyping.
Yeah.
Something like that. If you ask it urgently, we can get it within a week, about 5 days maybe. Yeah, but in the normal conventional flow, it indeed takes a few weeks, yes.
Thank you. If you allow me, I'll ask Dr. Bassam one more question. حياك الله دكتور بسام. عندي سؤال على قضية ناقشنا من أمس واليوم، أنه يتكون عند الطفل الشخصية أنه ذكر أو أنثى في خلال السنتين الأولات إلى 5 سنوات. إذا في حالة مرضية الجينات والأعضاء التناسلية الداخلية كلها أنثى، لكن ما اكتشف المرض إلا بعد عمر 16 17 20 سنة، الآن من الناحية الشرعية مسموح لي أنا كطبيب أني أنصحهم بأن يتركون الشاب هذا كما هو، ولا يفرض علي أني أنصحهم أن يحولون إلى أنثى كالأصل؟ لأننا زملاء مختلفين، يعني في المجال حقنا عندنا أطباء يقول أبدا شرعا لازم تقول لو عمره 30 50 أنه ينقلب إلى الأصل، وفي ناس يرون أنه بما أنه تكونت الشخصية يعني اللي هي الجنسية أنه تتركه خلاص بعد 5 سنوات، تحترم وش اللي تكون عنده من شخصية. رأيكم الله يحفظك.
هو سلمك الله هذا عرض. احنا عندنا ايضا اجتماعات في مجلس التعاون الخليجي، انا عضو بالافتاء بدولة الكويت، فبالتالي الله عز وجل ما قال ومن كل شيء خلقنا زوجين لعلكم تذكرون. فالحقيقة لما يكون هذا امر عرضي قد يكتشف في البداية، يعني أنا لحقت مع الأخوة والأخوات الأطباء وجدنا أن في أول شهر، ولحقنا يعني آخر حالة كانت عمرها 15 سنة، فبالتالي في تفاوت. فإحنا واجب علينا، الله عز وجل يقول ولا تكتموا الشهادة وما يكتمها فإنه آثم قلبه، وإذا قال فاسألوا أهل الذكر إن كنتم لا تعلمون، وقال وفوق كل ذي علم عليم، لأن هذا راح يترتب عليه أمور كثيرة جدا كما ذكرنا في قضية الميراث، قضية الشهادة، قضية الولاية، وقضايا كثيرة جدا، قضية حتى اللي هي الإمامة والخلافة وغيرها. فهذه الحقيقة تكون بالنسبة لعدم تكتيم مثل هذا الخبر. ولذلك نجد أن في عهد عمر بن عبد العزيز رضي الله عنه حدث مثل هذا، لكنه كبر، ولما كبر وجد أن يعني الآلة اختلفت، فصار أن يعني من أنثى صار ذكر. فبالتالي قالوا له يعني أمير المؤمنين هذا عمره 35 سنة يعني طيب أو 30، فبالتالي قال يجب علينا، هذا أمر الله تبارك وتعالى، هذا علاج. فالله عز وجل عفوا النبي صلى الله عليه وسلم يقول تداووا يا عباد الله، ما أنزل الله من داء إلا وأنزل معه دواء علمه من علمه وجهله من جهله. فبالتالي هذا يعتبر من العلاج، يعتبر من الشهادة، وما يجوز الحقيقة كتمانها. وبالتالي نخاطبه، نحاول قدر الإمكان يعني مشايخ في الدين أو علماء النفس وكذلك الاجتماع. وأنا أعتقد أن هذا الأمر الحمد لله طيب في كثير من الأحيان. إحنا هذيك المرة كان في اجتماع في مجلس التعاون الخليجي، يعني عام تحديدا 2000 يناير 2024، كنا ناخذ على الحالات الموجودة كالإفتاء. يعني 2024 ما شاء الله كان عدد حالات مجلس التعاون الخليجي الخليجيين وصل العدد إلى تقريبا 35، غير الخليجيين وصل تقريبا إلى 90. فبالتالي الحمد لله يعني من المخاطبات وكذا وكذا تم تغييرهم. اللي ما رضى من اللي هو الوافدين راح بلده تقريبا 50 حالة مو راضي يعني. لكن احنا في النهاية نعتقد أن هذا ملزمين أن نخاطبهم ونعالج مثل هذه الأمور، لأن الأحكام ترتب عليه. يعني أنا بس الشيء بالشيء يذكر، أنا أيضا في يعني مستشار في إعداد الأبحاث الأميرية، فالشاهد أنه عرض علينا، أنت تعرف أحيانا في ضغوط سياسية، فقالوا يجب أن تخلون الواحد الأطفال خاصة إذا وصل عمره 11 سنة أنه يختار يبي يحول أنثى ولا ذكر وكذا. فالحقيقة أنه كان عندنا مشاكل سياسية، لكن الحمد لله على طول اجتمعنا والجانب السياسي خاطبنا، نحن لابد أن نهيئ الناس أن هذا كلام غير صحيح، وبالتالي تصدينا لمثل هذه الظاهرة الخطيرة. فبالتالي احنا انا اعتقد ان هذا الواجب علينا ان ما نكتمل الحديث، ان اختلف الاطباء يرجعون الى اهل الشرع. واحنا ايضا لما قال الله جل فاسالوا اهل الذكر ان كنتم لا تعلمون، اهل الذكر اللي هم انتم الاطباء. واحنا الحقيقه الحمد لله ان هذه القضايا ما تؤخذ براي دكتور واحد، لا بد ان يكون مجموعه. والله عز وجل يقول وتعاونوا على البر والتقوى ولا تعاونوا على الاثم والعدوان. تفضل. يعني انا اقول يجب
عمره 27
ايه
اول مره دايجنوز، يعني اول مره شخص الهيئه رجل كامل، الهيئه رجل، لكن اكتشف بالكروموزومات انها انثى ولديه اعضاء تناسليه انثى. هل الان انا ملزم كطبيب اني احولها لانثى؟ لانه تفكيره كامل الرجل، هيئته كامل الرجل.
دكتور يجب علينا أن نحوله أنثى، لأن هذا هو الجهاز، مو قضية الظاهر. القضية أن هذا متعلق في قضية أن ولا تكتموا الشهادة، فإحنا نقول له ونقوم بهذا العمل ونساعده على هذا. إبراهيم عليه السلام أبو الأنبياء وحبيب الرحمن وأول من يكسى على أرض المحشر، متى ختن عمره 83 سنة، زين 83 سنة. ما قال والله أنا ما أختن وأنا 83 سنة. هذا أمر يجب علينا أن نصدع فيه، وحتى يعني نبذل قصارى الجهد. وهذا اللي يفرق حقيقة إحنا كمسلمين عن غيرنا، أن إحنا ما نأخذ في الاعتبارات العاطفية لا، إحنا نقنع الناس في قضية العاطفية والنفسية والاجتماعية، لكن في النهاية نصدع ونوقف معاه ونأخذ بهذه المآخذ. يعني حتى من علامات الساعة أن يعني تشتبه على اللي قدامك، ما تعرف أنثى ولا ذكر. وإحنا حقيقة أنا أدرس في كلية الشريعة، صار لي الحين 45 سنة دكتور في كلية الشريعة. الحقيقة أحيانا يجينا واحد ما تدري هو رجل ولا المرأة، يعني صراحة. فبالتالي نطالع الشكل نقض البصر، قال الدكتور أنا رجل ماني امرأة. طيب فالشاهد أن هذه النماذج موجودة، لكن أنت في النهاية يجب أنك أنت تصدع وتخبر. جزاك الله خير. أنا آسف طولت حيل.
لا أبد، بارك الله فيك.
Thank you for our speakers. Now we're going to move to our coffee break. We're going to just do 10 minutes and we'll come back for the next sessions. Thank you.
حياك الله دكتور، يعطيك العافيه. الله يحفظك الله يحفظك.
يعني أنا I got the chance.
As you can imagine, but I believe to when they were students, but now they are not students anymore. So it's interesting to me because of the stuff. Unfortunately, I couldn't understand cultural issues. I'm used to which is so I'm used to
الرجال تاخذ لي حق على اخر سلايد شفته
Would it be
نشوف حالات أنا ما نشوف هاي العين أبناء عندنا يومين شو من كاتب مرضى ديون يمسكون فيكم روانية ماشيين صح سيدة مش دلع والله شوف منهم والله ينبعدهم بس يمسحون فيكم الحمد لله. أقول له العلاج مو هني مرواني، أقول له مرواني أقول له عندكم. أقول لهم ما عليك منهم.
بس تروح اسمان ولا
يوم الخميس بكره إن شاء الله. يجي واحد أقول له ها شلون دكتور أمير شفت الباب وأقول له يعني منطقتكم غير منطقة مليون شوية صح؟ لا مليون مليون يعني كأن الصين شعبية. الحمد لله.
احنا قربنا
كلها خير
ان شاء الله.
بعدين تحسنت الفرق
ان شاء الله. الواحد بس مش عايز يخش لما يستقر
ان شاء الله خير يا رب. الله يبارك قول امين يا رب.
بسم الله الرحمن الرحيم والسلام عليكم. Welcome back to the last sessions. Myself, Dr. Zaidan Mazidi, pediatric endocrinologist, and Dr. Amir from Farmania, same, pediatric endocrinologist. Our topic will be about how to speak with children and adolescents who have DSD. And the speaker will be our Heidi, who is psychologist. Please, Dr. Heidi. There should be an IT man here for any problem. IT man should be here, IT, for any problem, for the technical, everything.
Yesterday I talked about how to speak with parents. Okay. Yesterday I spoke about how to speak with the parents when there's a newborn baby with a diagnosis. And today I want to speak about how we work with the children and adolescents themselves. First, a bit of theory. Like we mentioned before, of course, we manage, or we try to monitor the gender identity, but we try step by step guiding the disclosure process. Of course, we follow the needs of the parents in that process, but we think that it's really important for the child from an early age on that they have words to describe their medical condition. Because we've got the feeling in our culture that when you don't mention anything, when they just come and have the medical visit and they do not know what's happening, that their fantasy is far more worse than when they actually have age appropriate words to describe what's going on. Like we said, they come also to me for the decision to take cross hormones, but also for the daily concerns, like when they go to friends or they go to school, what do they need to do when they need to change clothes and stuff like that, or when it's difficult to ride on the bike. I'm going to switch quickly to a case already. This was a boy who came over to me, and the doctor referred him to me because he didn't know for sure if he wanted to start testosterone. We started once again, but with explaining that he is okay in the way he was at that moment, but that it's sometimes confusing for the other children or other persons around him. And I started to use like the body diagram I showed before, but I also tried to explain the concept to children like from the inner and the outside, like the babushka dolls I put in. For children, they do not know naturally that there's a distinction sometimes, like, okay, it's you like to wear female clothes, or as a girl you like wearing trousers and playing soccer, and you have a lot of male friends, but it doesn't says anything or all about your gender identity, the inside. I use thermometers also to explain that to them. I'm going to show them a bit later, but I'm a psychodynamic therapist and I use projective tests also. And over there we can quite often see at a child level already which kind of gender identity themes they are following. Like for this boy, I could tell there was a male identification. Even in words, he said, I don't know. You could tell that he was more upwards to the male identification, even when his body felt ambivalent at times. Another test I like to use is I Feel Pictures test, because it gives information about how they deal with emotions from themselves and from others. And for me that's quite an important tool when I need to give information for that particular child, that I know the child on a deeper level. And then the thing I mentioned before, for the children it's important to stay in charge. This child, you can tell his head, hands and feet were green and the rest was all orange. at that point, it's important to hear why the child did this. For him, it was because he felt he was a bit overweight, but that was not the case, but in his feeling it was. These are the thermometers, and you can tell again, I draw it with the child, it's co-working, and at the left you can tell the outside, with who he played at that moment, the way he looked, and then the inside, his gender, how did he felt at that moment. I really make sure that the child knows it's a temporary thermometer. It keeps on going on every time almost I see them. And for this boy, you could tell at the outside, both males, female friends, stuff like that. And inside, at that moment, he was a bit more going to the female side. After a time, or also a long time again, we started testosterone once again with a really small dose, and for these children I used that kind of guidance form where we look at every time when they come over before they go to the doctor. I ask to him like which kind of body changes they already felt, going up from 0 to 10. Are they used to the developments already, the changes they feel, also from 0 to 10? And do they like or dislike the feeling and the changes? And then after that, we make a decision like, okay, can we build up the frequency of the testosterone, or do we need to build up the dose? And luckily, we have a medical doctor who takes that into account. And for the children, it's really important. And when we sit together, I take out that form, and they know, okay, we can talk and discuss about it. For the adolescents, I've mentioned already before, for the developmental stages and tasks they need to go through. For them, it's tough. They feel at that age more that they differ from other teens, and quite often they feel really lonely, and we need to look for other teens who have same-like condition, so that they can share. And my experience is that quite often they want one-to-one contact, and not always the group contacts, but one-to-one. And for them, the medical consultations are tough. We prepare them, we make time for that, we schedule and reschedule if necessary. So we try to help them with those also. Like Birgit mentioned before, sometimes I've got youngsters who already want to know the information about the dilatation, because some tell me like it's up to me to decide wherever I want it, but if I don't have the information already, how can I decide if I want to? So we make clear, okay, you've got the information, you can think, you can rethink up until your 20s, 25 or whatever. And I quite often contact the schools, not to tell them the whole diagnosis. I seldom do it, only if the child really asks it. Normally I don't, but I try to explain to them that there's a reason, a medical reason, that this child has a difficulty sometimes in following certain lessons. Because when there's a late diagnosis, like within the girls, then it's quite often the exact time period at the school that they have like the sex education lessons. And we can tell at that moment, when you just find out that your fertility is not good, and then you've got to follow those lessons all about getting babies is too tough. Also a case report. This girl came young to me with this kind of diagnosis. It was a girl who already seen a psychologist in the neighborhood. She was quite soon overwhelmed by things that were happening. And the parents and the girls were really afraid, like, how am I going to handle with this kind of medical condition? To my experience, because sometimes parents are a bit scared of what can we tell already, and like you said, we give information age dependent, but how can you feel what this kind of child can already handle? To my experience, children are really good in ignoring stuff. They hear something, and if you ask, can you repeat it, or can you, it's gone already. And quite often they remember the stuff they already can handle, and the other parts they forgot, but in a certain way they pick up words already if they ever want to ask a question about it. Then they pick up a forgotten word, and then they ask some blunt question. We think, okay, they pick up stuff, but they can handle at that moment what they can handle. For her, she had really specific questions, like what do I do when all my female friends have their menstruation, how I am going to react. So for her it was really like, okay, she didn't want to tell a lie, but what can you say? Quite often it's referring to certain body parts, like say something about your belly, that's not a lie, and try to feel a solution for that particular child. Like I said, contacting the other teen was important. And for this girl, and it's for me an example of how it's different for each girl. This was a question I never experienced before. She had the feeling that, like, okay, I don't menstruate, but I got a feeling that I experience my cycles, but it's always dropping on me. I don't know how my cycles is, my period. And for her, she wanted to gain control of her body by seeking symptoms like, okay, maybe I'm a bit more angry, or I feel more tired, and she had like a diary with all for her the particular symptoms, and it was really comforting for her, like, okay, I start to know my body, I'm a bit of in control. So for me this is a good example of, it's not like a certain theory or something you need to follow, but once again talk to that particular child, ask and follow the pathway he or she wants, and uses a lot of concrete material, the drawings, the questionnaires to talk through, to ask about all the specific domains, like school, friends, and my experiences is all one by one, and build up trust, but giving words is really important. So thank you for your attention.
Second presentation will be how to establish a DSD clinic. This is by Professor Martin Kurz, Dr. Hans, and Miss Heidi.
So for the last talk, we would like to zoom out a little bit and talk about how to establish such a team. So this is a presentation on behalf of everyone of our team, and Professor Coles will also be available for the Q&A as a coordinator of our team. So why do we need a multidisciplinary team? So as you are aware, DSD is a very complex disorder, and it's not only complex medically, but also families, they face very complex decisions, such as gender assignments, interventions, gonadectomy, how to adapt and how to respond to others. And really no single specialty can take care of all of that holistic care. Also, general medical management is more and more shifting towards a more patient-centered approach, and this is where multidisciplinary team clinics are really in an ideal position to be able to accommodate to such an approach, where several healthcare professionals work together to achieve the best results for the patient. And also evidence shows that this approach improves patient satisfaction and outcomes, which is why multidisciplinary teams have been a cornerstone in the last few international guidelines. So such a team obviously brings together the expertise from different specialities. It allows the coordination of these different specialities. Team meetings help with that coordination, help with improving the communication, bringing that together, preventing errors, preventing redundant investigation, ensuring consistent care. So as mentioned, the patient-centered approach is really the main importance of this multidisciplinary care, and which then again improves the patient outcomes resulting from that shared experience, leading to more comprehensive diagnosis, effective treatment strategies, and improving the well-being of the individual so they can themselves be more involved in their diagnosis and be more involved in the decision-making process. And this decision-making in DSD especially is very, or need to be made very carefully, because the interventions can have lifelong implications. So they need to be made evidence-based in mind as much as possible. Families need to know what the decision process is, so it can be transparent, which again builds trust. With the patient in mind, not only their medical condition specifically, but also their psychological context, the social context and cultural context kept in mind, where we try to involve the patient as much as possible in an age-appropriate way. Of course, they cannot participate when they're still very young, and we have to engage with the family, but as they mature, we need to try to explain to them as much as possible what is happening and listen to them so they can share their opinion as well. We need to make a distinction between curative and non-curative scenarios. In DSD, very often intervention are not for life-threatening indications, and sometimes a sense of urgency can be created by the family or by other healthcare professionals. And we as a multidisciplinary team need to be able to balance that urgency with caution, recognizing that sometimes decisions can and should wait until the patient is able to participate themselves. And then finally, Finally, there are a lot of legal and ethical aspects in these decisions. So decisions about closure or disclosure or interventions always need to be made with the ethical concepts in mind, and also within the local legal framework. And for these types of decisions, it is of course impossible to make them alone, and that's why also it's essential to have a team to be able to make these decisions together. So, and such a team is often formed organically by caregivers with a genuine interest in the pathology, in the population, with expertise that come together to start working together. And at a minimum, there should be some pediatric specialties that form this team with endocrinology, urology, or surgery, or psychology. And then ideally there's also a geneticist, gynecologist, pathologist, or fertility specialist present. And to provide further support, a sexologist, nurse specialist, social worker, educator, or patient representative can be very beneficial. And of course, transition into the adult care is essential with the participation of the adult disciplines as well. Of course, the composition of such a team can vary according to the availability, the local context, or the individual expertise of these team members. And coordination is key. So a multidisciplinary team needs a designated lead, someone that has the trust and mandate to be able to facilitate decision making and to ensure cohesive communication. And this role can really be taken up upon from any of those team members. So I mentioned transition, and this is an important process. It's not a simple handover or transfer from pediatric to adult care, because there's a great risk of fragmentation and loss of follow-up. So it needs to be a controlled progress where there is a change from the family-centered pediatric care to ultimately the individual-centered adult care. And during this process, it is essential to involve the patient as it grows up, to explain to them as much as possible, to in a way that they understand, so they can again be a part of their own diagnosis and the decision-making process. And the need for information changes gradually as well to involve, for example, questions about fertility or questions about sexual function. And at the moment of transition, we have a joint consultation with the pediatric and adult specialty to facilitate the transfer, to build that trust as well. And during this process, the psychologist also plays a key role. The moment of transition also presents an opportunity to be able to connect the patient with a psychologist. Sometimes patients don't feel the need to talk to a psychologist, or they don't want to, but it can be a good opportunity to introduce one to them as part of the mandatory process of the transition, so at least they have a point of contact in case the need would arise in the future. And there has been some guidelines drafted that can help to coordinate that transition process. So this slide shows a bit the typical flow through a DSD multidisciplinary clinic, from the first point of contact to the long-term care. So it starts with an entry point, which is most often in newborn with atypical genitalia, or an adolescent with puberty concerns. But it can also be already prenatally with DNIPT or anywhere during life. And then the family or patient is introduced to one of the team members who can help coordinate the next few steps, moving into the diagnostic phase with hormone tests, imaging, genetics, based on the evaluation of the clinician. And then the case can be presented in multidisciplinary team meetings, can discuss the diagnosis, plan the management, and all of this information is discussed back with the patient to explain as much as possible what is happening and what the process is and what the options are. And during this whole medical process, the psychological care is a key parallel process to be able to provide support and to be able to also to connect them with their peers. And of course, DSD is a long-term long-term follow-up is needed, where patients and families need a recurrent point of contact. We need to prepare them for transition, gradually involve them, and of course if new problems arise or if the need for information or care changes, this can always be discussed in the recurrent multidisciplinary team meetings. So surrounding all of this care is the psychosocial care, and ideally should not be a one-time consultation, but is an ongoing process. And we, as mentioned, have joint consultation with the pediatric endocrinologist and the psychologist to really help with this. And finally, ethical considerations. It's essential to make decisions as a group. These are decisions about irreversible procedures. And it really helps also the members of the team are on the same page. If views differ wildly within the group, then this can pose challenges as well. So DSD is an ongoing field, and it is important to remain up to date, and a genuine interest of the caregivers in the pathology and in the population really helps to be up to date with the research, to help being engaged with registries, for example, to be up to date of the latest trends of new clinical practices. And it's also important to be monitoring yourself the outcomes of your care. There's a lot to learn from the patients as well. They can teach us a lot of how they wish to be approached, to be to how to participate, and feedback from the patients really learns us a lot as well. So, of course, there are some challenges. DSD is a rare disorder, so if you don't have the patient, it's also difficult to build expertise. So that's why usually such multidisciplinary teams are in tertiary centers or collaboration between centers. In some countries, the health organization also is really a driver for the development of multidisciplinary teams, but in other countries, resources may be lacking, and it's really then up to the initiative of the healthcare providers to start such a multidisciplinary team. Then again, there are also logistic problems. If you want to have joint consultations, definitely if the resources are not available, and also for the transition, we also have joint consultations with the adult and pediatric specialist, which can be difficult if pediatric and adult care are on different campuses. In our hospital, these are on the same campus, which makes it a lot easier to have joint consultations, but this can pose a challenge if they are on two different sites. For families, it can be difficult to adapt, and parents might have different views than the team. So families need time to absorb the information. So it's essential to provide them all the information they need, the support they need to be able to build trust with the families. Communication is also an important part. It is within the team, because as a multidisciplinary team, we need to be able to work together. Team members may have differing views on the governance, on the management, on the psychosocial support. So communication is essential, and respect and trust among the team members really helps to support this, because this is really also necessary for consistent messaging to the families. And in extension, there's a huge benefit if the team members are also interested in the speciality and the fields of the other specialist. So they are open for their views and their input in certain situations and decisions. And then finally, there are very few practical guidelines. There are no official quality standards, practice training programs. So this is very difficult, and it's why it's important to be engaged and be up to date with the research, which of course requires a lot of commitment. To illustrate the flow a bit with this case of a 17-year-old girl with a primary amenorrhea, which is referred and meets our pediatric endocrinologist. Her personal and family medical background is uneventful aside from the absent pubertal development. There is no breast development, and an X-ray shows a bone age of 13.5 years. The genitalia are typical female, and she has felt increasingly uncertain about her body given the absence of puberty development, and she would like to start medication that can start breast development and menstruations. So diagnostics is performed with hypogonadotropic hypogonadism, AMH is undetectable, and there is a 46XY karyotype with no further causes on the exome sequencing. So the findings are discussed in our team meetings with the diagnosis of congenital or complete gonadal dysgenesis. The bilateral gonadectomy is proposed given the risk of malignancy, which is performed a month later by our surgeon, and the pathologist saw an extensive gonadoblastoma on one side and a pre-invasive dysgerminoma on the other side. The results and the management is discussed with this girl. She is informed as much as possible and given her wish for female pubertal development. Estradiol is started. This was for her devastating to hear that she did have a Y chromosome and that she could not have any children of her own. And so she was followed up by our psychologist. Yeah, thank you. Several times. And after a year, she participated in a DSD family day where she met other girls like her. And since that day, she felt much better. And a couple months later, she participated in a TV show explaining about her condition, what she has gone through, but that she's now happy and proud of who she is, and she wants to help and give hope to other girls in the same situation. So this is a nice illustration, and there's also some research proving the benefit of a multidisciplinary team in DSD. Here on the x-axis you can see the score for structure and organization of quality of care. On the y-axis the satisfaction of patients, which there is an association. And then just another example, here again on the y-axis the satisfaction, with on the x-axis for different categories, where in the orange bar there's the patient satisfaction for multidisciplinary team clinics, and in blue the regular primary care of disorders without a multidisciplinary team, and also compared to the green bar of multidisciplinary team for other indications, where you can see the multidisciplinary team has a higher patient satisfaction compared to non-multidisciplinary team, and for DSD it is similar as other conditions, with the highest scores for the interpersonal manner, the communication and time with the doctor, which shows that the patient and family really appreciate being felt heard and supported. So establishing a multidisciplinary team is both a challenge and a great opportunity. These are rare disorders, and this is the standard of care. It's important to have an engaged team that can work together, coordinated with the patient in mind, to do family education, patient education, support them as much as possible, connect them to peer networks. The transition is a very important process, and that we need to evaluate and learn from the patients and be engaged or be up to date with the research as much as possible in this evolving field. So thank you very much.
Any question for the speaker?
This is Dr. Marwa Al-Ghadibi, a consultant endocrinologist, adult endocrinologist. I'm really grateful for the opportunity to meet my pediatrician colleague in this really very enriching opportunity in an area which is really of common interest between both of us. My question, the point is that I can't stress on the importance of the MDT enough. And really this is one of the areas that we would like to implement in a more structured way in order to improve our current practice. I have a specific question regarding the transition care or transition clinic. I think that we are missing the practice, the appropriate practice of this kind, or handling this kind of, clinical care. What is your experience regarding the transition readiness tools? How do you think, are you applying these in your clinical care? And how do you think that are they effective in, because as an adult endocrinologist, I'm a caregiver, and I do get cases from the pediatric side to my side. And sometimes I feel that it could be a bit early to be transitioned, or the other way around. So do you think that implementation of these tests is appropriate by our side as an adult, adult endocrinologist, or how to proceed from there? Thank you very much.
We do take a lot of care into consideration in the transition process, and try to prepare them as much as possible. I also think maybe in Belgium we transition a little bit later than in other countries. Now you were referring to specific tests. As a geneticist, I'm not actively involved in the transition process, so I'm not fully aware of those tests. So maybe it's better, if afterwards you can connect with our coordinator, which may be able to help further. Or
Maybe it's easier that I just discuss now. We do have these transition readiness questionnaires. There are several of them existing. Our experience is that they are not always adjusted to the typical setting you are working in, and that's why we have actually compiled around 5 of these existing questionnaires, and have picked the various questions that we thought were relevant to our healthcare insurance system, to our way of working, and so on. And we have a nurse, pediatric endocrine nurse. In the months before the transition clinic, we arrange a consultation of the adolescent with the pediatric nurse, and she will go over the questionnaire and give us feedback like the adolescent is fully ready, or she needs some additional knowledge on this or that. But if you take just one questionnaire and you apply it without adjustment, then often it's very difficult for the adolescent to answer, because usually, for example, the healthcare system in the US is very different from the one in Belgium and so on. So that's why we modify it a little bit. And then it works quite well, I think.
Thank you.
correct? DSD
No,
workshop.
no. We are done with the lectures. Dear colleagues, as we come to the conclusion of this workshop, I would like to thank each of you for your active participation and valuable contribution throughout our discussion on the challenges in diagnosing and treating pediatric disorder of sex development. Today's session highlighted not only the complexity of these conditions, but also the importance of early diagnosis, multidisciplinary approach, and a continuous support for patients and their families. In closing, I extend my deepest appreciation to our sponsor, the Ministry of Health, Pediatric Council, the organizing committee, our distinguished speakers, and all the participants. May this workshop be a step forward in improving care and fostering collaboration in this critical field. Thank you very much.
Which syllabus?